Today.
Oh, goody. Good morning, everybody. Good morning. I'd like to welcome everybody to the Appropriations Health Agency presentation. And I think we've canceled this either one or two times. Either it's been weather or it was the IT system or we got here and I'm really happy. I wanted to let everybody know the lineup today for the hearings before I start. From 10 to 11, we have the Department of Public Health. From 11 to 12, we have the Department of Developmental Services. From 1 to 1:30, we have the Department of Veteran Affairs. From 1:30 to 2, we have the Office of Chief Medical Examiner. From 2 to 2:30, we have the new Office of Health Strategy. And from 2:30 to 3:30, Department of Mental Health and Addiction Services. The public hearing for the health agencies will be held on March 9th. I believe we start at 10 o'clock, but I'm not exactly sure. But I will try and find that out and let everybody know who's watching us today.
Madam Chair,
Yes, ma'am.
that is correct.
Oh, okay. That's okay. Madam Administrator, what time will that public hearing start?
Yes, you were correct on both the date and the time.
What did I say? 10:30?
You said 10 a.m.
10 a.m. Okay. Oh, I was on task. Oh my gosh. And it's Friday. I feel fulfilled now. Everybody, just to let you know, all of us are running. Even though Appropriations is overwhelming, we're committed so much that we have other memberships in other committees. So my co-chair is in a committee and several of our other members are in there, but they will be coming in and they will also be tuning in for what they can. And for everybody's information, this will be televised on the CTN, I believe right after the end of the day today. So the people who couldn't get there, they will be able to hear. So all of that said, I'm out of breath now. All of that said, I'm welcome, Commissioner, and welcome to Appropriations, and go right ahead.
Thank you very much. Good morning, Senator Austin, Representative Walker, Senator Berthel, Representative Nuccio, Senator Hartley, Representative Exum, and Representative Paris. Thank you for the opportunity to testify before you today in support of the governor's biennium budget for fiscal years 2024 and 25 for the Department of Public Health. You have my written testimony in front of you, so I will be summarizing my thoughts overall. Before I do that, I would like to do two introductions. With the start of this new year, we have two new deputy commissioners at the Department of Public Health that I would like to introduce you to. The first is Dr. Jody Terranova, who is a pediatrician and was at University of Connecticut for over 10 years and trained at CCMC, so has been in Connecticut for a very long time. And second is Lisa Morrissey. And Lisa has been in local health throughout Connecticut in 3 different health departments in our state, different regions of the state for over 10 years. So the complement of new leadership we have at DPH reflects some of our priorities and where I see us going forward. And it's been great to have them on board and leading with me, our team at DPH. So as we are emerging from the COVID-19 pandemic that I was brought in to help respond to, I want to just talk a little bit about where we are headed as a department and specifically in regards to the governor's budget. So we know that COVID shook our world in many ways, but we continue to have emerging infectious disease threats that our society faces. Mpox, formerly known as monkeypox, was the first example of that test that came to us in 2022. And the reason I bring it up is because we had to operationalize many of the skills that we had in COVID and translate them to a new infectious disease. And I bring that example up because the investment in the department mostly through federal funds to be able to help us scale up for the COVID pandemic, was able to allow us to assist in diagnostics, vaccinations, screening and testing throughout our state. And we're very fortunate that for many, many weeks, we've had 1 or 2 cases that have been identified, but we have been able to respond to this threat. Similarly, we saw this winter the combination of RSV, COVID, and flu. Again, being able to respond and work with our hospitals, work with our schools, work with our local health departments when you have a new threat or that might be slightly different than we've seen before. We need to have the agility to be able to do that, scale up, scale down. That's one of the things we are going to be continuing to do in responding to emerging infectious disease threats, which I anticipate we will continue to have them as we go forward. One of the second areas that we are focused on is climate and health. And one of the ways that we are operationalizing that focus is through the bipartisan infrastructure law that the Connecticut State Department of Public Health is getting sufficient and significant, I should say, funding to be able to address many different areas, specifically drinking water, lead service line replacement, and PFAS treatment. And so those are 3 major areas that we are looking to focus on in this year going forward. We have an Office of Climate Change and Public Health that was established as part of the Governor's Council on Climate Change, or the GC3. And that group will also be taking a closer look at how climate impacts health here in Connecticut. We have many states that are ahead of us in this regard, but it is an area that we will be looking at as well and partnering with our federal partners. Third is an area that I consider revitalizing public health. And that is all the things that were put on the back burner during COVID, but I specifically want to highlight them for 3 reasons. The first is gun violence as an example. And the Community Gun Violence Commission that was put together in the last session has been hard at work, and $400,000 was invested in the fiscal year 23 by a mid-biennium budget adjustment for DPH to establish our community gun violence prevention program. We have been hard at work at that. We also are working with a contractor to be able to, that should be in place by April 1st, so that an RFP can go out for $2.5 million that will be awarded then to subcontractors who will be doing work in the community, specifically on gun violence intervention and prevention work. And we're also pleased to see that in the governor's proposed budget going forward, another $2.5 million in ARPA funds for fiscal year 24 would also go to this work. And that's where we will continue to build this out. And the office that we are establishing will be able to continue to work with community partners that get funding to do this work. A second topic in the idea of revitalizing public health is that of tobacco. So the Tobacco Trust Fund is something that has been established for a long time. It is operated through OPM. And over the next couple of years, $12 million is going to go to that board at OPM. This is a non-lapsing fund. And so as part of the governor's budget, $1 million is usually put towards DPH to do tobacco intervention. Instead, that will be going to this trust fund. And the fact that it's non-lapsing will be an advantage to be able to help us do this work longitudinally. And we look forward to working with the trust fund to be able to operationalize those efforts that are going to be so important. And then third, I just want to highlight maternal and infant mortality. So we have a maternal mortality review committee that has been longstanding at DPH for quite some time. I get monthly reports after this committee meets. It is federally funded, but as part of the governor's budget, there are funds that are going into starting to look at infant mortality. And this is across the spectrum, a little bit different than what the OCA does. But really our goal with this is to be able to look at public health interventions that could be done to try to reduce infant mortality. And that would then be in tandem in a way with our maternal mortality that we've been looking at. So I get a report on a monthly basis. Maternal Mortality Review Committee gives recommendations after they have sort of trends and can see recommendations that can be made over a period of time with a yearly report that they generate. And we envision that the Infant Mortality Review Committee would have a similar type structure as time goes on. And this investment will be able to let us start doing that work. A fourth area that we're going to be working on is workforce development. So this is an area that obviously through our governor's budget and through our executive branch, the Office of Workforce Strategy has been working at very hard for the last many years, but specifically for public health workforce, which, obviously involves the department and local health departments. There was an investment that we were successful in receiving a federal grant of $32 million that will go towards public health workforce development. 40% of those funds are going directly to local health departments, and that was mandated by the CDC for them to be able to use as they see fit and as they need to. But we are also using some of our funds in a partnership with Connecticut State Community College to establish an associate's degree in public health to be able to really build that workforce pipeline of people that are going into public health. That will bolster the efforts of the healthcare workforce development that's really happening through the Office of Workforce Strategy. Along those lines, the fifth area of focus of mine is local health capacity building. And just to share with you, I'm with DC Morrissey. We've been making tours of the 61 health departments and or districts that we have in our state. We've made it to Norwalk and Hartford so far. We will be continuing our circuit throughout the state. It may take me a year to get to all of them, but basically at once a week, we are making our way through. And I think that through our workforce dollars and also really building that cooperative relationship and making it clear that really to do public health most effectively, we need to do it as a team. This is a team sport, cannot be done at the state level and local level separately. It needs to be done together. And then lastly, I just want to reference reimagining the long-term care industry. We know the challenges that long-term care may have had before the pandemic, but certainly became highlighted through the pandemic. And so going forward, first, I'll just mention, many of you do know Barbara Cass, who's here as well. She was our branch chief for healthcare quality and safety, retired from that, has been working as a TWR, but has decided to come back to the Department of Public Health family, and she will be a senior advisor to the commissioner's office on long-term care. And the reason that this appointment is so important is because of the challenges that we see in this industry. And in the governor's budget, there is funding of $531,000 specifically over the biennium to support 3 positions in our healthcare quality and safety branch, specifically focused on building a quality assurance program. And this is really critical for us to be able to follow the various different complaints that come into the department as investigations are done, being able to track them and have a holistic picture of where we stand, particularly in the long-term care industry. So with that, I will stop and take any questions that you may have.
Well, you've got a busy calendar for you for DPH. I know all of you that you want to, I already know, I know who's going to ask the questions. I know what's going to be, I know those because I know. So I'll stay away from their subject matter so that we can try and maximize the time. And I know Representative McCarty, you have questions also, so this is going to be good. And Representative Dillon already piped in too. So we've got a lineup here. But I'm going to first ask what we ask everybody automatically. In the budget, you have listed here 472 staff people with an additional 9 from insurance. Can you tell us how many of those are filled positions and how many are in the process and how many are just funded but not filled?
Yes, absolutely. So we have, as you said, 472 authorized general fund positions. We have 313 filled positions. We have 77 that are in process and 159 general fund positions that are vacant. But in addition to that, we have the 9 insurance fund positions, as you said, 6 are filled, 3 are vacant. We, in addition to that, have federally funded positions. So we have 341 filled federal positions and 179 vacant federal positions.
Okay, so
This gives us a total of 660 filled positions, 77 in process, and 341 that are vacant.
okay, so let me just make sure. So under the federal, we have 341 filled
Correct.
and 179 vacant.
Correct.
Okay, and in the general fund budget, you have 313 filled, 77 in process, and 159 vacant.
Correct.
Okay, and then in the insurance, you have 6 filled and 3 vacant.
Correct.
And then in total, it is 660 filled, 77 vacant, no, 77 in process, and 341 vacant.
Correct.
Okay, all right. I'm going to start with the,
Okay, I'm sorry. I just want to give a clarification.
Sure.
That Michelle Schott, our Chief Operating Officer, gave me, which is that the 77 that are in process are a subset of the vacant.
I'm sorry, say that again.
The 77 in process positions
Uh-huh.
are a subset of the vacant positions.
Oh, okay, okay. Oh, I'll go and fix those up later.
I
Okay.
apologize.
That's okay. I get the gist of it. I get the
Yeah.
gist of it. Okay. I'm going to ask, I have been looking for information from your department since December, and I've asked you twice.
Mhm.
This is the 3rd time. I need to know what are the rules and when and things that are being established for mobile dispensing units in Connecticut.
Okay, so we have policies and procedures, as we have discussed, that are now developed by our department. These policies and procedures will be what will be the governing strategy from the Department of Public Health on these units. This is a multi-agency response.
Mhm.
Part of DPH's response is to create those policies and procedures for them to be operational. There are other aspects by other agencies that need to be done as well. I will ask Barbara, do you want to comment a little bit further, specifically if you have specific questions on that?
Well, let me, before we get into that, what I'd like to know is at what point does the legislature get to hear and read these rules so that we understand what is being done? So that if we have concerns or objections to any, at what point do we get to weigh in on that?
So policies and procedures,
Uh-huh.
which I have just approved, are going through they get posted at some point. Now, after that, there would be regulations that are developed, and that is the process through which the legislature ends up weighing in through that regulatory process.
Through the regulatory process or through the
Submission of
to
regulations,
the,
submission of regulations.
which is much more reduced in access for legislators because there are only a few that have access to it. During this session, we all have access to it, but then once you take it out of session, then it is not, we are not really part of those conversations. Those regulators are there, but we do not have all of us that are going to have access to that. So I just want to say that this is a very big concern for me and many of my colleagues, because this is an unknown entity doing something that we still have not gotten our hands around as far as what is a good neighbor when an organization that is in a community dispenses medications like methadone, et cetera, and how we as a community have a voice to understand and be able to explain our concerns. So I do have a bill that I'm pushing. And if we have to, and if I bring this to all of my colleagues, there may be a cease and desist until we get that information. So I'm just giving you that notice right now, because I've asked And we couldn't, if things could have been shared with us, it would have been a little bit easier for us. And we figured we could get some of these things through. And many of my colleagues have said, well, where are they? Where are they? So I just want to say that is a huge concern, because many of us have concerns about things in different departments, especially in health, that go on in our communities, and we don't actually know what's going on. So we can talk about it offline, but we really need to have access to that information so that we know that the people in our communities have their voice. And I'm sure we'll hear that during our public hearing. So I'll leave that one alone. Now on the ARPA, you had a lot of money that was given, that you had access to in ARPA from last year. So I'll just ask a couple of them, because I'm sure my colleagues will probably ask for more of them. But the lead paint, I think there was, I forgot how much, I can't see because the print is too blasted small. But it was a lot of money. What was it?
$30 million.
$30 million. Yeah, that's exactly what it was. So where are we with that $30 million, and how much money have you used, and how much of it is going to have to be moved out or is going to lapse?
So our program regarding, this is for lead remediation in homes, separate and apart from lead service lines involving water systems and through the bipartisan infrastructure law. There was a working group that met over 6 months, developed plans on what needed to be changed in the laws in Connecticut. And there is a bill put forward to make those changes so that they can be operationalized in the lead remediation as we go forward. Now, the actual spending of funds, we want to do this right, and we've wanted to do it in a way that was going to be able to be operationalized in our communities, because that is going to be done at the local health department level, department and district.
Okay.
So one of the things that DC Morrissey has been focusing on since she has come into this job is how that actually is going to happen. And we've been able to leverage her connections with local health departments to really get a sense of the way that we're going to be able to do this best going forward. So that's the system that is being built now. We know that there are programs and departments that have been very experienced doing this kind of work, because they have had this as an ongoing problem for a longer period of time. And we are looking at being able to fund them to be able to continue to do those abatement measures and procedures for the homes that are affected in their communities. There are other areas of the state where we've had multiple different health departments come together into districts. And so they may be larger areas of the state, and figuring out how we can best partner with local health departments and or districts to get the best coverage and the most efficient execution of both identification, abatement, case management going forward. So that is the system that is being built right now, so that the money can get out the door to be able to fund those efforts.
How much has already been expended?
We have not expended funds in this regard.
30 million is intact?
Yes, but yeah, we have not sent any out to the, but again,
So
I think what I want to just highlight is we
Mhm.
wanted to make sure we got this right.
Okay.
And after the budget was passed last year, 6 months of the year went into figuring out new levels that had been established. What is the impact of that? What is going to be the impact of those new levels? What is the magnitude of the problem? How is that going to affect different communities? And that's where the working group for 6 months, basically until the end of December, which then resulted in that report, which is now informing how we build this program and the new bill that's put forward. So I just want to give that context in terms
Okay.
of why that funds have not been spent yet.
So nothing has been expended of the
Correct.
30 million.
But we would get back to you to know for sure, but that
Okay.
is my understanding.
So is that reflected in your budget? I don't see it. I didn't see the 30 million listed in your budget anywhere.
Because it's, yeah, right. So it's 20 million from last year and 10 million this year. Together, total, it's 30 million.
Okay, so it's 20 million last year.
Right. And it's the 10 million from this year that's reflected in.
Okay, and the
The-
10 million is reflected in here. Okay. 1 second. I just don't want to make it redundant, so I'm just checking because I want to make sure I'm not asking questions that people want to ask. So what I'm going to do is I'm going to pause and let my colleagues have a chance, and then I'll come back after that. So Representative Exum is first. Representative Dillon is second. Representative Gilchrist is third. Representative Datham is fourth. Representative McCarty is fifth so far. Okay. Go right ahead.
Good morning, Commissioner. Good morning. That's too far. Good morning. Thank you so much for your report, and the areas of emphasis are so important. I just wanted to ask for an update around the healthcare, the school-based healthcare centers. How many there are, what's going on with those? If you could please provide an update.
Yeah, absolutely. So we have about 200 school-based health centers in our state. And I believe approximately 79 are funded through the general fund, approximately. But we have three main buckets of funding as it relates to school-based health centers. The first is general funds, and that is what I was just referencing. The second is CDC funding that we received specifically for school-based health centers. And we have a contract with the School-Based Health Alliance that issued a request for applications, and they are going to award subgrants from that fund. That amount of money is approximately $12.5 million. And the School-Based Health Alliance has received 135 applications right now that they are reviewing to be able to support the expansion of the workforce and school-based health centers expansion. So they will be looking at those applications and then awarding sub-grantees at that period of time. The third pocket of money that we have is ARPA dollars, which is $10 million that was put from ARPA budget to support the expansion of mental health services specifically. DPH is issuing an RFP for an organization to issue those subgrants. So that is where we stand on that right now. Also, just as a side note, Intercommunity Healthcare received a separate ARPA allocation of $604,000 that was not included in that $10 million amount that I mentioned of ARPA funds. And that is also for the expansion of behavioral health services, and contracting is underway for that process.
Thank you very much. And in that one bucket with the expansion of workforce, how does that look at that expansion? I know there's a need for workforce in multiple areas. That you need the public health side and also the mental health side. I know there's a great deficit. So what does that look like?
You're talking about specifically from the CDC funded expansion?
I think that's where that.
Yeah,
Yes.
that was part of that. So I think it's going to depend on the applications that the School-Based Health Alliance received in different ways that people proposed to bolster that. So they have those 135 applications. So I think it will be dependent on how different people propose to address that specific concern.
And then the mental health supports, what are you saying there? I know we are really trying to expand the amount of services, and yet
Right.
I hear about workforce all the time being the issue, the provider issue. So how's that being addressed?
So I think that, again, there's the specific piece of the school-based health centers expansion for mental health that is through these ARPA dollars.
Mhm.
And that is still in process, because getting the contractor who's going to administrate the sub-grants from that's a little bit still ways
doing
off.
that.
But what I would say is that we've also seen through our licensing division that in the last session, we passed the SIPACT, We've had many people start to join the SIPAC to be able to be a behavioral health provider in the state of Connecticut. In addition to that, we now have reciprocity. If you have had a license in good standing in another state, you have a fast track to licensure in the state of Connecticut. People have been able to get this license very, very quickly. I've received emails from grateful licensees in other states to say how streamlined that process was in the state of Connecticut. So we are making progress in terms of having behavioral health providers in our state. We also know that the longer term expansion of the behavioral health workforce, our Office of Workforce Strategy received $30 million that was specifically to go towards nursing and behavioral health workforce expansion. And there was a kickoff press event just earlier this week at Cornell Scott Hill FQHC in New Haven, which is going to be a site where trainees can go and get that training. And we have 20 different nursing programs, and also there are some behavioral health programs as well that are getting funding through this specific ARPA program. And so I think we're starting to see all that investment that was done in last session now actually rolling out into the community. Now it's going to take time for nurses to get trained, for other behavioral health providers to be trained, but the short-term fixes that we tried to put in place, like the SIPAC, like reciprocity, they're already having an impact, and we'll see more over the years to come.
I am so glad to hear about the licensure, that the reciprocity, it has been effective. And I think it's just really important to state, and I'm sure I'm making an assumption, but I think it's true, that it does not diminish quality, that it only opens up more options. Can you tell how much activity has come as a result of that, or what we can expect to see as a result of having people take advantage of those different programs?
I can certainly get back to you with more numbers on the number of people that have utilized the reciprocity feature that we now have in the state. I can tell you anecdotally that as I mentioned, that I have seen that we have certainly had people taking advantage of that, and it's been quite streamlined, very fast.
And one last question around the candidates who are applying. Are you seeing more diversity?
I would have to get back. You mean in terms of ethnic and?
Yes.
So I would need to get back to you in terms of whether in this short period of time of a year, we've seen more diversity on that. Overall, I would say there are a number of different interventions that have been put in place so that over time we will see more diversity. But whether we've had a change in the last year, I'd need to get back to you.
Okay. Thank you. Thank you so much, Madam Chair.
Thank you. Are you ready for the question? Okay. Next we'll have my co-chair, Senator Austin.
Thank you very much, Madam Chair. So Commissioner, last year, Representative Walker and I had in the budget an increase for the private ambulance companies. You indicated that the language was not clear enough in a letter to us, you indicated that the language was not clear enough. Can you provide language that would make it clear enough? Our intent is to see the rates increase, and that is within the purview of the Department of Public Health. And so I would like to see what that language would be for you to require you to do so. We are getting continued complaints that many ambulance companies are going out of business because the rates are just unsustainable for them to stay in business. And we think it's in our best interest to make sure ambulance companies stay in business. So I would appreciate that language. That was not included in your letter to us. Your letter indicated that you didn't have the ability to do that based on our language. So I'm asking you formally for the language to make sure that we see a raise in the rates of private for private ambulance companies for private companies to increase their rates to pay ambulances at a higher rate. We can take care of the Medicaid rates. We don't need you for that, but we need you for this. And so I need to understand why we haven't raised the rates in a decade or more. And based on today's prices, we all know that that's unsustainable. And we are right now seeing many ambulance companies, because they're unsustainable, being bought out by both Yale and Hartford Healthcare. And as far as I'm concerned, that's a bad move. And so if you could get that to us by the next committee meeting that we will have, the subcommittee meeting, that would be wonderful. Thank you very much, Madam Chair.
Thank you. Representative Dillon.
Thank you, Madam Chair. Good morning, Commissioner, and thank you for your testimony today, and thank you for your work. I wonder if you could provide to the work group and perhaps a reduction to language of some of the back and forth that we've heard this morning, but also an update on some of the very exciting initiatives that we were able to take up under difficult circumstances in the last 2 years. And that would include gun violence, which you have already mentioned. That would include a reduction to language and explanation of how you're going to be rolling out those dollars. I know we've been collecting e-coding for 30 years, so we should have pretty robust data in the Chimes data set, but I don't know how all that fits together. So that would be really helpful, and that's very, very good testimony this morning. The second would be, and it would include anything that we took up in the last 2 years, but period poverty, what the status is, you can provide to the work group of how you stood up that initiative and whether the dollars have gotten out the door or not. Your department was, and I believe I mentioned this to you offline, as part of the pulse oximetry initiative, which was actually an insurance bill that did mandate your department to do materials that would reach out to clinicians. And I wonder if you, I know that you did complete that. And I wonder, just for the safety of the public going forward, whether you could have a slight discussion at the subcommittee level and in the work group. And also, I guess, a question about whether or not you've looked into doing public education, let's say, of young people who are carrying these devices around and may not necessarily know the issues. So those are all simply things that we adopted in the last 2 years. My second question, I guess, would be about what your testimony is about this morning, and that would be to flesh out a little bit how your infant mortality initiative will work, and also climate, which is very exciting on a policy level, and whether or not you're going to be working with our own state agencies like transportation, which is, as we speak, removing our tree canopy. That would really be exciting to discuss at the level. And otherwise, I'm pretty much done. Thank you.
Thank you. Thank you. Thank you, Representative. Oh, I'm sorry. Did she ask? She just basically gave you a list of things she wanted. Yeah. Okay. I thought
That's for the work group. We don't need to discuss
right.
it.
That's what I thought. Okay. Representative Gilchrist.
Thank you, Madam Chair. Good to see you, Commissioner, and your team. This is something I would love to have brought to the work group as well. So would love kind of like a chart or just to understand better what takes place in the Office of Injury and Violence Prevention. So what staff, the programs, what private providers get funding, the total budget, the programmatic budget, and then how that money is distributed. Would just love to get a picture of that.
Okay.
The next area is with regards to contracting. I don't know if you have answers today or again could bring this to the work group, but with regards to private provider contracting, I suppose this is for the working group. Just I've been hearing from folks that it's taking quite a bit to get the funding out the door. And then I'm told there's this back and forth. Maybe it's the Attorney General, maybe it's Department of Public Health. But regardless, people aren't being paid. And at this point, it is impacting services. And so just want to get my head around, what's the required reporting? Is that quarterly? Is that annually? Is it monthly? What's the length of the contract? What's the pay schedule? And then would love, if possible, to see what's that actual distribution of payment. So when is it supposed to be paid? And then when are folks getting those payments? And then my final question, which I think we maybe could discuss today, is in the budget, the tobacco control funding. Just is this a cut? Is it being moved? To me, in reading it, we put in 12 million for the first time in a very long time. And it appears that this is a cut in half. Just wondering the thoughts behind this. Am I not reading it correctly? Thank you.
Thank you. I'll answer a few of those questions, and then the bigger questions around injury violence we'll come back to you with. I just want to comment a little bit about contracting. So first of all, in April of 22, Michelle Schott, Chief Operating Officer, was hired. In the process of that, we have really started to revamp all of our operations at DPH, which were quite behind. And the organization was able to respond to COVID, but really was sort of focused on COVID and had to get things in place to be able to do that. But in terms of our regular operations, some of what Michelle has done since she's been in the position is setting up different groups within her unit as operations, and one is a grants and contracts unit. The leader of that unit has now been hired and is away at work. We have 27 positions in that group. Many of them were vacant for a long period of time. In the next 4 months, roughly 4 to 6 months, we anticipate being fully staffed in that group. We have been laser focused on improving contracting and payments. As people let us know if they are having troubles, we have made provisions to get things in place so that immediate important services that are happening in communities do not stop, especially for smaller providers that really run on small margins. So we are very aware of this. We're doing everything we can. It's been a top priority of mine. It's been a top priority of Michelle's, and that is going through the organization. We have additional staff that are working with our AG's office to streamline that and reduce that back and forth communication that has been part of the tradition of a contract between DPH and the AG's office, so that we can make that, again, more streamlined. So I know it's not perfect right now, but I do think that over the course of this year, I'm hoping this will become less of a problem for people that we work with. On your second question on tobacco, what I just want to highlight is that the Department of Public Health has gotten $1 million every year. That $1 million is being transferred to the Tobacco Trust Fund, which is going to be implemented and it sits within OPM. And that $12 million, which is in the biennium, is going to be in that trust fund. So I do not see this as a reduction in any sort of way. I see it as a conglomeration of our funds that we've normally put towards this with the 12 million that are in the trust fund. And the trust fund has really not been operational for some time. So this is going to be able to put more focus towards this work going forward.
Great. Thank you. Thank you, Madam Chair.
I just have a quick question on your contracts. Do you have an evaluation and if I get $100 from you, do you put in my contract something that says you must provide this in order to be in compliance with the contract? Do you do that?
That is the very basics of a contract.
Yeah. No, but everybody doesn't do that. So
Well, yes, and I believe that our Attorney General's office in our conversations, would also ask that of us, but yes, we do that.
you do that? Okay. I just because
And that's part of our reporting,
oh,
which
good.
was some of the questions,
Yeah,
in terms of
yeah.
like what is required, when are payments
Okay.
given out, but yes, we do that.
We've asked some agencies along the way, and everybody doesn't have that.
I
so-
see.
So, thank you, Representative Datham.
Thank you very much, Madam Chair. And just to follow up on the contracting question, do you facilitate contracting purchases within our local DPHs? so that they can get some sort of extra buying power and, discounts and sort of things like that, because a lot of the needs are the same.
So one of the things we did, for example, through COVID, is that if a master contract for something is through DAS, then it has the ability where local health departments would be able to purchase off that master contract as well. So we do have a few situations. That's something that we had done in the past in that way. I think that going forward, that's something we can also consider. I don't know, Michelle, do you have any other comments you want to make on that, or? Right, yeah, so so any contract we have through DAS is available to any local health department.
Great, thank you. My second question really has to do with the lack of nursing home oversight. I've been concerned. I sit in Human Services, which committee today? And we heard a lot about that in the last couple of weeks, especially at our hearing last Thursday, which I'm sure you all heard. Would love to get some response from you from some of the folks and the things that were talked about at that.
Hey Siri, call Joe O'Leary.
Thank you. So as I mentioned, nursing homes is an area of focus for our department this year and going forward, no doubt. Part of the reason the request for these 3 positions to have and build, which we do not currently have, a quality assurance department within our healthcare quality and safety branches for this reason specifically, because we provide oversight through surveys and complaints that we receive, but being able to have a holistic picture on that and be able to make sure quality continues to maintain in nursing homes, that budgetary request will really help us be able to provide that additional oversight and that ability to be able to provide quality care and hold nursing homes to those standards that we expect of them.
That's good to hear. And I would love to hear maybe within the work group, some specific examples on how that's worked, so that we can get a better understanding and how we plan to continue to address that. The next part of that question is something I'm hearing from some local service providers, particularly that provide sort of housing support services in our safety net. And they are talking to me about medication certification. I'm glad to hear that you've had that local capacity project that you're working on and visiting all the DPHs. But from what I'm understanding from our local sort of boots on the ground, is they're having a difficulty with the online management ability to administer and kind of keep you guys in the loop with the different medication management in regards to how they teach their employees and train their employees to administer medications. And I'm not 100% sure how that sort of licensure works. And so I was hoping you could bring to the working group how you're doing that and how we're able to facilitate that sort of process, both for the training on the end, on the administration side of being able to administer medications, because from what I'm hearing in a lot of these sort of group home environments, this is something that's been an issue. Thank
Okay,
you very much.
just to clarify, because mostly DPH is not involved with medication administration, but you're talking about specifically in group
Well,
homes?
I was looking at sort of group homes, and I'm
homes.
thinking it has to do with around licensure. And then when you started talking, and this is what got
Right.
me thinking, was when you were talking about one of your priorities about the local health capacities, I was kind of wondering the sort of connection and how we're able to do that, because this is an issue, and I'm sure it's not just an issue in the group homes. I'm sure this is an issue everywhere, and would love to hear how the licensure process works. What are we doing to facilitate things from an IT basis to make sure that it happens a lot faster? I'm sure Ms. Cass is looking at this. She's nodding. And so, yes.
And
thank
I
you.
think one of the things I would just highlight is I think it probably has its most impact in residential care homes where we do have oversight. where medication administration is done in residential care homes. And one of the reasons that I've appointed Barbara as a senior advisor in this role is because residential care homes, as an example, used to be a place where many older women who didn't have many comorbidities sort of lived out their years maybe. And it has become a very different patient population. Often many people with mental health disorders, also sometimes substance use disorder, a variety of comorbid medical conditions, which is why medication administration is so important in that group. And we do not have the regulatory framework in place to hold such homes accountable really to the standard that we would want. And this is one of the reasons why it's an area of focus that I'm hiring her back out of retirement in this capacity so that we can really look at how we would do that better and what we would want ideally going forward.
That's great. I mean, anything we can do to facilitate what's happening with the boots on the ground. We have such a workforce shortage. Everybody knows that. And we'd like to make sure that we keep our people in the social safety net safe, but also facilitate utilizing technologies to make that process go better. And I'm glad to see Barbara back on board. She's been was a complete star during the pandemic to me and some of the things that we were working on in New Canaan. And it really it was phenomenal. So thank you, Barbara, and thank you for coming back. Thank you, Commissioner. Thank you, Madam Chair.
Thank you, Representative McCarty.
Thank you very much, Madam Chair. Welcome, Commissioner, and to your staff today. Thank you for your testimony. Representative Dathan and I always thinking about nursing homes together. So she did bring up the healthcare facility quality assurance and performance improvement program, which I'm very pleased to see. But would you be able to bring to the working group how you envision those 3 positions working perhaps with other agencies that are, I'm thinking the ombudsman program and different agencies with it that the department may be able to work with to assure that this works effectively. And secondly, looking through your budget, I see there are many programs that are zeroed out because of federal dollars that were used. Would you be able to take a look at those programs and let us know how the Department of Public Health will continue to do that work, where you envision that may be picked up? And there was one section that it was said non-federal grants, and it was around $500,000 or so. Would you be able to bring back and tell us what those grants are and how those are used? And then, if I may, since I'm going very fast,
Yeah.
under infection control, I've always been very concerned about tick-borne illness in the state, and we've had such an increase. Could you just speak for a moment where in the budget I could find that and what the department is doing in that regard?
So if I can just make one comment, because that we'll come back into the committee with a number of the answers. I think one of the things to just keep in mind in general is that Department of Public Health usually is about 1/3 state funded, 2/3 federally funded. Much of our efforts in these regards are federally funded. Right now, we're about 85% federally funded, 15% state funded because of the influx of COVID funds that we had. And so a lot of the areas that may seem zeroed out may be being funded from other grants that we have. And that may be part of what you don't see in terms of the whole department's response. So we have close to $1.2 billion that came, 85% of which is federally funded to be able to respond to COVID and many of the other things that have been consequences of that. So I just wanted to put that in some context.
And I appreciate that. I didn't realize that it was really that many dollars that were all federal dollars, but I do know you're creative and try to find ways that, because some of them looked fairly significant to me that were zeroed out. So
We'll
anything
come
you
back
can do to enlighten
Sure.
us on that area would be helpful. And then on the tick-borne illness.
So in tick-borne illnesses, we have a surveillance unit that is constantly looking at tick-borne illnesses as they happen through our state. We report those over the seasons as they come. And we're constantly looking at whether we should be testing for new things at our state lab. For example, our state lab now does Powassan virus testing, which is also a tick-borne illness. And those types of efforts at epidemiology and surveillance is where a lot of our efforts go as a Department of Public Health. But we also work with our partners, for example, at DEEP. You know, if we look at mosquito control, tick control, the environment and climate, that was one of the other questions that was raised, is something that we have to be paying attention to all the time. I think we work very closely with DEEP on the climate related issues. And to your question on the nursing home related issues, I have specifically been told that our collaboration in Connecticut of DSS, the Ombudsman's Office, and DPH is really far superior than many other states. And that's what we've already had going on in terms of our collaborations together. But certainly we will continue to collaborate in that way with this quality assurance department, but we can come back to you with more ideas of how we plan to operationalize that.
Thank you very much. Thank you, Madam Chair.
Thank you. Representative Khanna.
Thank you, Madam Chair, and thank you, Commissioner.
Could you speak a little closer to the
Oh,
microphone?
yeah, sure.
Thank you.
Thank you. In your budget, you have funding for inflation, and we're just wondering, how are you supporting funding for inflation in the local health departments?
I may have to get back to you on that. I don't know if do you have anything else right now? I think we'll have to get back to you on that. You mean in terms of the per capita dollars?
Yeah,
So if inflation's been accounted for in per
yeah,
capita
because
dollars.
there's some, from the general fund, and then there's X-ray screening and tuberculosis care, but does that address other inflation measures for the local health departments?
Okay, we'll get back to you on that.
Okay. Thank you.
Thank you.
Senator Austin. What's
Uh,
your name?
I don't know what it is. At this point, I'm not certain I remember my name, but Commissioner, I have a couple of different questions that are not connected at all to anything. And one is on the gun violence prevention, because we have two different line items in for gun violence prevention. What do you do with the gun violence prevention dollars that you get?
So last year was the first year that this commission was established. $400,000 was to build our group that is going to be focusing on that work within DPH. $2.5 million is split up in two ways. One is through ARPA for the community violence prevention. That's $1 million. 1.5 is to address increases in homicides, also through ARPA. Those are the funds that are going to go to the contractor that is going to issue subcontracts to people who apply to that RFA. So our contract will be established by April 1st. The working group that worked over 6 months to really understand the scope of the problem and where interventions could be done going forward over the 6-month period in 2022, put together the RFP that will be issued along with our Department of Public Health experts, and that will be issued by that contractor after April 1, when that contract is in place, when sub-awardees will be identified through that mechanism.
So again, what is the time frame for the subcontractors to start working on this?
It will depend on the contractor who's going to issue that RFP. So that should happen after April. Our goal would be that money should be able to go out by later this summer, but it is going to be dependent on that process.
So is that normally, is it that long of a time? So we finished the budget last year in May, and you're saying later that's this summer, so that would take at least a year and 2 or 3 or 4 months to finish a process like that?
So it was the desire of the legislature through what was passed last year to set up the commission.
Yep.
It was not given just to DPH. So the commission needed to meet. The
Yep.
members that were outlined in law had to come together. That is what happened that resulted in working groups from that. And there was a group that specifically worked on the RFP. So it's not just that DPH had to get this RFP out the door. The commission really needed to get together. That happened over 6 months. The RFP is now ready, and that the contractor needs to be identified. So I think this has been done as quickly as was possible, given the charge.
Fair enough. And relative to programs, because there are a number of programs that work on gun violence, Project Longevity being one of them, Compass, and mainly in Hartford being another one that are very, have very good results based on the work that they do from the bottom up of the communities. And so I'm curious, are you looking at them as being subcontractors? Or are you going to look at new programs? These two, that I know that these two have a significant track record for coming up with good results. So do you have any idea?
Sure. So the commission met on this, and there was a group specifically that talked about exactly what you're asking about. And the goal was to be able to fund people who have track record and know that they've been able to do this work, but also bring novel ideas to the table and be able to bring groups that may need technical assistance, may need help in being able to actually operationalize and execute new ideas that may be brought to the table. Evidence-based, which is what we really want to do. And so all of that has been spelled out in the RFP. And one of the goals of this RFP is to cast a wide net, let the best applications come through. And then there's a series of criteria to be able to identify who should get funding. So on the one hand, the commission felt that people who have done this work and have documented success in doing this work should get credit for that. On the other hand, we also want to make sure that people who are close to the community, working in the community, maybe have ideas that would work best in a community, if can be demonstrated through an application, should be evaluated on those criteria. So that's what that review committee will ultimately do when they select who the eventual applicants selectees are.
I appreciate that. I also know that a lot of times people can write a very good report and still have no results that would come out as a result of that. And that concerns me, that we would try to go in a new direction when we have proven success in groups like this. So you could bring that process that they will go through to this subcommittee workshop, that would be great. Relative to contracts that you have to do for new water systems. Most recently in one of the last bond commission meetings before, I think it was before the first of the year, might have been right in January. There's a group in Lebanon that has an at-risk water system. Have you reached out, has your agency reached out to them to develop that contract with them yet?
Lori, do you have any additional information on that? I'm not familiar specifically with that contract. We can get back to you with more information. Do you have anything further?
The Carefree, Carefree, yes. Okay, great. My last question is I'm sorry, my mind works in bad ways, really bad ways. I'm trying to figure out what we're doing. We looked at coming up with a staffing ratio for nursing homes, and you set the staffing ratios. And my understanding is the staffing ratio that is being set by the rules and regulations from DPH is different than the staffing ratio that we called for in the budget, because we put a financial number on that staffing ratio. And this is going to cause an increased cost to nursing homes. And so to the working group, if you wouldn't mind bringing back your analysis and what you came up with as a result of a fiscal note, because by my analysis, we would have to at least increase the fiscal note by half. And so I just want to make sure that if that's going to be the case, that you're also supporting us putting the dollars in for the nursing homes to comply with the staffing ratio you're setting up. And it does not appear to be so right now. You may have a different analysis, and I appreciate looking at that, but that is not what I see right now. So if you wouldn't mind bringing that to the working group, I'd appreciate it. Thank you very much, Madam Chair.
If I can just make one comment on that, the fiscal note really would be DSS, because we don't do that piece of it. What we're operationalizing is the 3.0 request that the legislature put forward.
And we did a combination and you're separating it out, doing LPNs under the CNA numbers. Your numbers are much higher than the numbers that we have. And while I appreciate that you don't pay the nursing homes, if you set a rule or regulation that increase the cost of the nursing home, that has to be part of our consideration in accepting those rules changes. And that's what I'm concerned about, because the only money they get, group homes, nursing homes, the only money they get by and large is from the state through Medicaid. Very few private payers in any of this. And if we're going to increase their costs, even though that is not your responsibility, I think there needs to be a collaboration, because your analysis increase their cost. If you increase their costs, then we need to know about that. And if you're not talking with DSS, we're not going to know that. We happen to know it because as soon as you did that, the increased costs came to our attention.
We've been in direct conversations with everybody in the industry and DSS. I just want to highlight that our goal and our understanding from the law, the way it was written, was to increase facing time with patients. And that goal was to provide care to patients. And just to highlight, even increasing to 3.0, it is the lowest out of our surrounding states.
I'm
So
not
just
saying that
wanna
we shouldn't do this.
Make
I'm not
sure
saying
that our focus is quality of care. That's all.
I understand that that's your focus. I'd like to do everything as quality of care for everything that comes before me. Everything that comes before me has a fiscal note, and I have to say no to people that want to do things. I have to say no to educators. I have to say no to firefighters. I have to say no to ambulance services. I have to say no to group homes. You can't have a rule that increase their costs without us knowing about it, because that puts them in a very difficult position. And it puts us in a difficult position because we have to incorporate that cost into our budget. And that's my concern. And I don't want any agency coming to me and saying that they're concerned about quality of care when I'm also concerned about quality of care. I have to pay for it. All of us here are paying for it. And so to say that, I find that to not understand the process, and that worries me. So if you wouldn't mind bringing your analysis to the group, that would be great. Thank you. Thank you, Madam Chair.
Thank you. And thank you, Commissioner, for coming. I would, well, no, because we're now 10 minutes into DDS. We can, whatever questions you have, we can, and I'm just going to say for us, I'd like to have a recap of all the things in the American Rescue Plan that are in your budget, where they are, what process they are. It's about 26 million and then an additional 25 million. So we'd like to know where they are with them, where's the distribution, and if it's going to be carried over into the next year. So thank you.
Thank you.
Thank you for your testimony. Thank you for bringing your team up. Thanks. Have a good day.
Thank you. You too.
Oh, I'm sorry. Just and go ahead, ask your question and go ahead quickly.
Thank you very much, Madam Chair. Quickly, I did notice that the immunization and the vaccine in the governor's budget doubled. If you could just bring us back some information on what you're doing. And I know you've said publicly that you were not mandating COVID vaccine for children. Just if you'd clarify that. Thank you.
There's no mandate for COVID vaccine for
Right.
children. Thank
Right.
you.
No, but she wants to know what the increase is in the budget.
We will bring that to the subcommittee.
Thank you. Thanks, guys. Have a good day. Thanks. Next, we have Department of Developmental Services, and they are from 11:30 to 12:30, and then 1:30 to 2, Department of Veterans, 2 to 2:30, Chief Medical, 2:30 to 3, Office of Health Strategy, and 3 to 4, Department of Mental Health and Addiction Services. Good morning, sir. Good morning, sir. How are you?
Good morning. I'm well. And yourself?
Pretty good, pretty good. I just want to say I'm so glad it's Friday.
I won't disagree with you, Rep.
For
Walker.
every hour of the day that it ticks, I'm just thinking it's Friday, just make it, not enough caffeine in any of my cups of tea. Go right ahead, sir.
Thank you. Good morning, Senator Austin, Representative Walker, the rest of your esteemed colleagues. I'm Jordan Sheff, Commissioner of the Department of Developmental Services. Thank you for the opportunity to come before you. I have a much longer written statement that I've submitted. I'm just going to summarize some highlights and then be ready for questions. Let me begin, as I did last year, noting that the impact of COVID-19 pandemic on our service sector. The availability of preventative and therapeutic tools has certainly improved outcomes for individuals supported by DDS in the last year. However, ongoing related workforce challenges that you're well aware of have continued to be a challenge throughout both public and private as we seek to return all supports to pre-pandemic status. One way in which we're addressing workforce challenges is through the historic investment of federal funds through the American Rescue Plan Act. I have details on these initiatives in my written testimony, which I'm happy to go through in further detail if you'd like. I'm excited to have the opportunity to partner with stakeholders and truly change the trajectory of our service system to offer individuals with intellectual disability the best possible supports. Governor Lamont's proposed 2024-2025 budget supports all of the goals of ARPA, HCBS implementation, allowing us to think creatively to offer the most integrated and individualized supports to as many people as possible. I also have details on the proposed budget changes in my written testimony, which we can also review. Thank you for the opportunity to offer testimony here today. I'm in support of Governor Lamont's proposed budget, and I'm very happy to answer questions you may have, and I brought some staff to help me answer the questions I cannot. Thank you.
Thank you, sir, and thank you for bringing your team today. I'm going to start with what we all ask as the first question with any agency. Of the 2,457 listed in the general fund, how many of those are filled? How many are vacant? How many are paid for? And then how many federal do you have? How many filled and how many vacant?
I will do my best to answer all of those. Maybe not.
Let's start with the
So
2457. How many of those are filled?
So the 2457 is a full-time equivalent count.
Oh.
We actually currently employ and have filled 2,680 positions.
Well, so you've got 247 paid for, but you've got 2,600.
We have 2,680 people currently working for the department.
That's not full-time, all full-time.
That's a combination of 1,800 full-time and 850 part-time.
Okay, so it's 1,800 full-time and 800 part-time. Okay, and then
of the amount of positions we have,
Mhm.
there are currently 713 funded vacancies. 285 of those are part-time. 428 of those are full-time. Most of
I'm
those,
sorry, how many are full-time
428.
of the four? Okay, 428 full-time, and the part-time was how many?
285.
285. Thank you.
We currently have an active recruitment. So of the 713 total funded, active in recruitment, there are 438 positions, 260 of which are in the direct care series. So for our 24/7 operations.
Okay. Would you bring this to the to the
Sure.
meeting? But yeah, I'm glad you're explaining it to us. Do you have federal employees too?
We do not have any federal employees.
Okay, so these are all, okay, all right. All right, okay. Last year, you received some ARPA funding. Let me see if I can find it. You received about 24,500,000. One was for enhanced community engagement opportunities, 2 million. One was for one-time stabilized grant, 20 million. One was for Vista, 500,000, and another was to improve campuses for DDS consumers. How many of those have you started, begun, or
So I'll ask Scott McWilliams, our CFO, to reply to that. Thank you.
Okay, so would you, how, of the 24,500,000, where are we in your utilization?
So we have not expended any of the money as of yet. For the Vista, $500,000, we have negotiated a what's called a beneficiary agreement with them, and waiting for that for them to return that signed, and we can expend that money. For the community outreach, we're in the process of developing an RFP for that. For the community engagement, again, we are working on a process to camps, I'm sorry. For camps, we're working on an application form for the camps to apply for the funds. And then there's I don't have it in front of me. I think the last category is the provider stabilization. We need to develop an application process for providers to apply for those funds.
Okay. So of the 24,500,000, the only one really that you've addressed or started to address is the 500,000 for this. Is that correct?
Well, that's the farthest along the process. I mean, have been working with OPM to submit plans and have our plans approved. And, we need to have agreements in place to expend the funds to the organization. So we're not as far along. I mean, that's once we have that beneficiary agreement back, we can expend that funds. The other ones are farther behind, but we're in process for all of them.
Okay. Questions, Lucy? Questions?
Thank you very much, Madam Chair. And I had 27.5 million for the ARPA funding, which includes the 3 million of respite care for family caregivers. I understand that those funds for the families are right now currently limited to ARPA. And I know we're looking in human services, how we can extend those to make them full-time. What is the process for those? I was surprised that of all of these amounts, we still have 27.5 million of ARPA funding that's kind of waiting to be utilized, and we're not quite there. And I know our nonprofits and all of our service providers are seriously struggling. I'm hearing it day in and day out. So I know that 20 million will go to work very quickly once you all develop that application.
Yeah, well, thank you for the question, Representative Dathan. We'll bring to the working group a detailed breakout of current and future ARPA expenditures and some sort of schedules as to how we hope to implement them. We have dispersed money for stabilization outside of ARPA or for rate enhancement to providers within our current appropriation, but we can give a more detailed breakout of where those things are and a timeline for when we might expect those. I didn't know if you had anything additional to add, Scott.
I mean, Representative Dathan, will just say in terms of the ARPA respite money, we have begun expending that. I think we've expended over $1 million. That funding basically flow through our family grant process where families can apply for the funds and receive respite funding. So we received that in a previous period. So we didn't include it in our breakdown of this year's budget.
Got it, because it looks like here it says contract procurement process underway. Department has determined entity type and is working on contract amendments. So it sounded like to me that was still very early stage. Maybe I'm looking at the wrong sheet, but this is the CSFRF 29697 respite care for family caregivers of $3 million.
Yeah, so we had a respite we were procuring for, but there were basically two uses of that fund where we were going to stand up a respite center for people to bring their individuals to, but also families can procure for respite in their own home. And so we've already been dispersing that money in terms of the money that we had allocated for the dedicated respite center. We haven't implemented that yet.
I would just like to add, I was with the Lieutenant Governor last week at a grand opening of a children's respite center in Enfield that we funded in part funded in partnership with Edelbrook, a private provider. It's our first real foray into the private sector doing respite. I'm hoping it's warmly received and highly utilized, and we'll see more of that. And we did within our public services stand up a 7-day-a-week respite center in Middletown for more extended respites for a variety of reasons, which is operating on the former grounds of the regional center there.
Great. Thank you so much. I think this is so important for so many families. I mean, the pandemic has been hard on the folks in the IDD community and their families who are really suffering. So thank you for doing the work here. It's really appreciated. As you know, Commissioner, we've had lots of conversations about one of my favorite topics, which I wish wasn't a topic in the state, which is our wait list. And I very much would love to make sure that we really think about, and I'd like to get some more information. And I know OFA sent you some information request earlier this week. Would love to make sure we can get those items addressed. If you want me, I can rehash those now, or if you've got them handy.
I was I'm aware that Christina Gelman has requested that information. I saw emails this week from Scott to staff. We have to gather that information from a number of places, and we know the importance of doing that timely. My staff have a lot of priorities.
I know.
So
Thank
I
you.
think that is queued up and will be the next thing on our punch list to get to. And whether or not we have it all back in time for the working group session, we may not have all the detail that was requested. The request asked us to reshape the way we have categorized wait list and structure things. So the hard part in doing that is when you start to pull things apart and then put them back together, everything has to tie out to what we had already submitted. So that'll take a little bit of time, but we are actively engaged in working on that request.
As a former auditor, that's music to my ears because I love it when things tick and tie. So just to clarify within that, you are also going to be able to talk about sort of attrition from the waiting list, how it rolls from one period to the next, and how you're thinking about in your sort of 6-year plan, how that waiting list will move. You also talked about capital cost with the CLAs. I'd be very interested to know if any of the $27.5 million of ARPA funding could be used for that, or if it's already contemplated that's going to be used for that, or that's sort of separate capital cost.
So there is some flexibility with permission from the federal government to repurpose ARPA dollars not spent in one area. There are still some pretty strict guidelines. They keep adding, they have added additional rules and guidelines since they issued the money that we have to be responsive to. But we will consider that when and see if we often look back and say, what can we repurpose here to address what we need in the moment? So we actively do that, but then we have to make sure we can thread the eye of the needle with all the rules and guardrails that are in place.
That's really helpful. Well, we're looking forward to getting a lot of this information, particularly on the waiting list. We really want to make sure that the folks in our state that need services are getting the services, and that we are not just kind of trying to kick the can down the road when we're really addressing it. And I appreciate everything that your agency is doing. You've been a great commissioner, and we really appreciate all your work, and you have a great team. So thank you so much.
Thank you, Representative.
Thank you, Madam Chair.
Thank you. Representative Dillon. Yeah, Pat?
Thank you, Madam Chair, and good morning, Commissioner, and thank you for the work that you do. I guess for the work group, if you could provide us with an update on the status of Southbury, what the census is, what the current per diem is, and the result of your efforts to place people in the community. And I mentioned that it's obviously the demographics of the folks that we serve have really changed in a generation or two because of our thinking about placing people in the community, and because of improved science and people, even just antibiotics. So people live longer, which creates the wait list issue, which was not even an issue 50 years ago, probably. So I would really like to know, because I think what we all want is service expansion for people to get what they need and to ease the anxiety of many of the parents that we talk to for planning. What the forecast is for Southbury, and and what is happening there, how many people are there. And I guess my second question about Southbury would be, have we made any improvements to safety there, given our experience during the pandemic?
So we can bring much of that with us, and it's nice to see you. We can bring much of that with us to the working group. I will tell you that I had grave concerns at the start of the pandemic about what outcomes might be for people living in institutional settings. And Southbury in particular, but all of our intermediate care facilities, our larger institutions, fared much better than I would have thought, given what we knew. And I give that credit, one, to our clinical teams and the epidemiologist team at Southbury, and to our direct care staff who abided by the many constraints and conditions we put in place to ensure transmission wasn't rampant. That is not to say we didn't have lots of individuals positive for COVID, but we had very good outcomes for most of those individuals who did contract COVID in those particular settings. But we can talk about all sorts of things, Southbury. We have a lot of information we can provide, and I can provide some of that ahead in case you have more specific questions, Representative Dillon. But we have some general, we get quarterly reports from a remedial expert on some of the very specifics you just asked, and we can work to get that to you for the working group.
That would be great. Thank you very, very much.
Thank you. Senator Austin.
Thank you very much, Madam Chair. I have a couple of just different questions from your field of expertise, sir. A child in Connecticut is identified as being intellectually disabled if they have an IQ of 70 or less, or is 70 not considered?
69 or less.
69 or less. And so both Representative Walker and I have been doing a lot of work around the level of folks that are incarcerated, in particular young people. And I don't know if this question was already asked, and I apologize if it was. And we're finding that there are a number of young people that become incarcerated that have an IQ of 71 or 72. And my understanding is that they don't qualify for any services under developmental or intellectual disabilities if they have that cutoff point. Is that true?
It is not a hard and fast rule, but it is a strong guide that we use. There's, in addition to IQ, there's additional language in the statute that refers to adaptive functioning. And our clinical team looks at both. Often the IQ score is the prevailing harder piece of evidence, because adaptive function can be very situational, depending on how one is medicated, if one, all the different things that could impact any one of us in our cognitive functioning during the day. The IQ testing is pretty consistent over periods of time, and so the validity of using that is higher. I am aware that a number of states are considering, as I think some of the draft bills have speculated, other definitions that would determine eligibility and potentially, and I've talked to Walter Glom at the DD Council. We talk often about he has a very good eye on the national perspective on this conversation, as to other definitions that might be used instead of a strict IQ score. So I think that's where you're headed with that, Senator Austin, and I think that's worthy of discussion. It would certainly have fiscal impact, which I know you're also concerned about. So we'd have to be, one would have to be careful in crafting language around that we'd be prepared to pay for, or not run counter to the speaker's bill that was looking to ameliorate the wait list that would create a definition that would actually expand the wait list.
So, and I'm not Bill 5001 does deal with a lot of the issues, but I am concerned that people would become incarcerated because they had an IQ of 71 when they have significant other problems, which is why they ended up being incarcerated. I met with 20 folks in the town of Ledyard, and they brought their child that has intellectual disabilities but is above the score and is not receiving any help, in particular, once they age out of school. And so many of these kids are 18, 19, and they're getting no help, and the family is getting no help. And it's directly reflective of the hard and fast rule that many in your agency apply, even though it's very clear that the people need other help. And so that concerns me. And you probably heard my comments to Commissioner Jutani, and yes, I care about the fiscal nature, but what I really care about is that we're not taking care of people, and that Representative Walker and our team on appropriations are looking at ways to actually cover these issues. We're not trying to avoid it. What we're trying to do is realistically assess what we need. And I would say that we still pay for someone who ends up incarcerated. We pay a lot of money to when somebody ends up incarcerated. So I just want to make it very clear that we're trying to make sure that we are addressing the issues relative to this. And I know that you appreciate that consideration.
I do, Senator, and I'll tell you that there are individuals incarcerated who have IQs below 70. And we do work with the Department of Corrections and track what we refer to as our forensic caseload, which is people who have or are at risk of criminal involvement that move in and out of both systems. So there's a fair amount of liaising that goes on between the two departments, and our clinical teams, particularly our psychologists, track and look at those issues within prisons. I'm certain that in my conversations with Commissioner Durantis, similarly, they do something similar for the under 18 population who are at risk for similar type issues.
So if you wouldn't mind bringing to the work group the number of people that you have seen incarcerated under an IQ of 70, that would be very helpful to us to make decisions, because we are looking at the Department of Corrections, medical and mental health staff that they have, and we find them woefully short of the number of people that are there. And we want to make sure, again, that we're looking at all of these, and you know, it's this is not the first time that I've done a home visit with a cadre of families, and the exhaustion on the parents' face is heartbreaking when you don't see any end in sight of that exhaustion. So I just,
Thank
I
you
appreciate
for
that.
And I'd ask you to keep your eyes out. I'm not sure which committee it was sent to, but one of our moms has already submitted or is in the process of submitting written testimony for her son, who we serve in public, who was incarcerated briefly, and her gratitude for the work we were able to do to prevent further incarceration and to give him a very
Right.
purposeful life. So keep your eyes out for that testimony. I think it's poignant.
Yeah, we will. And then I also have a concern about intermediate care facilities. Last year, this is a continued frustration with Representative Walker and I. We actually went through the intermediate care facility funding, and we put in additional dollars for the intermediate care facilities. How many intermediate care facilities do you have under your umbrella?
I don't know the number off the top of my head, but we can provide that number.
That would be wonderful. And would it be fair to say that many of the people that are using the intermediate care facilities have significant issues?
I don't know if it would be fair to say or not. So at a time, several administrations ago, there was a decision for individuals served in those intermediate care facilities to not necessarily receive case management through us. So I have less eyes on the ICFs, which are, and I'm not trying to pass the buck. They're eligible for the department.
Right.
But I have less eyes on their needs at the ICF facilities because we are more minimally involved. But I can tell you that DSS, OPM, and DDS are in conversations right now, analyzing costs and using some of the tools we have to evaluate and assess the situation that is important to both you and Rep. Walker around this issue. But I don't have any. I don't think we don't have anything finished yet to share.
Okay, and that's interesting because both Representative Walker and I have been talking to OPM about this issue. We are very concerned that the people that work at ICFs are receiving less payment than the people that work at a regular group home. And by significant, what I'm really trying to get at is the people that live at an ICF have more needs than the people that live at a residential group home, so to speak.
There was a time where that was very true, and I could tell you without having to look at who's living there that that was true. In our private sector and the group homes, the non-ICF group homes that we operate, we support some really complicated individuals, both medically and behaviorally, that in prior decades would have been considered suited for an ICF, that we have grown capacity in the private sector. So I don't know, I can't tell you today that it's drastically different in terms of the care needs, but we can try and ferret that out for you.
That would be great. Would it, in the ICFs are in the private sector also?
Yes, they are.
Okay, I just want to make sure that we're clear about that, so people don't think that those are state funded. They're not. Well, they are state funded, but they're state funded to for a private provider.
Yes, and most of the providers, if not all of the providers operating ICFs are providers within our system as well.
And most of them have said to me that they've talked with you and that they're concerned about their rate of pay.
That is true.
Okay, thank you. And so I'd be interested in getting down to into the weeds on the ICFs in the work group, not right now. How many people live at Southbury?
I don't know if I have my census in front of me right now, about 125 or so off the top of my head. I can give you, we have a full set of data for that.
And how many other people how many other group homes do you have that are state run?
I have approximately 35 group homes run by the public sector. I have 3 regional centers operating in public, 11 respite centers operating in public, and Southbury. 11, I believe it's 11 public respite centers. Yep, I got that right.
And there are not, at the respite centers, they don't, people are not living there. Those are like a weekend.
10 of them are from Friday admission to Tuesday discharge, so they're weekend operations. We used to operate them more days, but we didn't have full utilization. And under the Malloy administration, we reduced the number of days from 6 to 5 and then 5 to 4.
So it's a 4-day. It's to
Friday,
give-
Saturday, Sunday, Monday is what most people stay.
So to give families a breathing room.
To give families, yes, the families get a break. The parents get a break from caregiving, and the one getting care gets a break from parents. And
Okay.
both are much needed.
And to the working group, can you please bring the number of people that are living there full time? So not the respite centers, but we know that there's 125 or so at Southbury. How many at the regional centers and how many at the 35 or so group homes? That would be helpful for us to understand.
Yeah, I can do so. I just want to, as you're looking at that as a reminder, the public has served as a partner and a backstop for some of the issues we've faced over the last several years in terms of what the ability for private providers to support some of our more challenging individuals, or during the workforce crisis, not so much their ability to support them, but not having the staff available to support them. And we have utilized public as a backstop for that when we all get calls. I'm certain that you probably do as well, from hospital associations or hospitals directly, that people are stuck in hospitals. Public has served as a place where we can at times consider placing somebody as opposed to them living in hospital ERs. So those numbers change, but I just wanted to put a plug in for our public staff who
I am not
unbelievable work.
interested in getting rid of the public facilities.
Then I'll be quiet.
You don't need to convince me. I am not interested in getting rid of them. I want to know the numbers. That's all I'm
I will
looking for
absolutely
is
get that to you, and I'm sorry for
to know the
begging the
numbers.
question.
Is the dental facility up at Uncas on the Thames now?
Yes.
Thank you. We'll talk about that at the work group too. Thank you, Madam Chair.
Also, could you bring to the work group, if people, if kids that are in the juvenile justice system that are thought of as having, being LD, what's the process that they would be that they would have to go through in order to qualify for any of your services? We'd like to know that, please. Representative McCarthy.
Thank you very much, Madam Chair, and welcome, Commissioner, and to your staff and for your work. If I could just go back to the residential services for a minute. I know there's a significant waiting list. If you would be able to bring to the working group, just breaking out how that program works. I know it's divided between family, different group arrangements, just if we can get a sense of the numbers waiting and perhaps how many are self-directed services. And then just on the behavioral support, I saw there was a quite a significant reduction of 4 million. Does that money come back into the agency with the age out? Number one, and if we could get more information on those behavioral support programs.
Yes, and we get all the data on that. Most of the change in our spending in that is because of other services now available in the state through state plan amendment and the EPSDT program, where families can also get services very similar to ours. But we can absolutely bring that. The other thing that I've offered to do, because we do have a habit of making things really complex, and what I offered Rep Case and Rep Dathan during our preliminary conversations on 5001 is to host a couple of deeper dives on specific areas so that legislators could get up to speed, so that if your interest is in our wait list, that we could spend a little more time and get to a little more depth. If your concerns around eligibility, if your concerns around respite, I often only get a few minutes here, and we pack a lot into that working group. With the investment, it looks that Speaker Ritter is interested in through 5001. I think it's important that people understand it even a little bit more. They don't have to know it the way I know it, but get more of the nuance and more of the detail and more of the way those things interplay. When you press a lever over here, it makes an effect over here. And so we'd be very happy to do that at the working group. And if you're interested in even more understanding, we would be very happy to do just a special, whoever's interested in coming and do a deeper dive into that.
Well, I would definitely appreciate that. And I know this is somewhat Senator Austin has approached this topic many times. We're concerned because we know the nonprofits deliver a great bulk of the services, and
95%.
Yeah, and there's such a workforce shortage right now, and some of that's tied to the wages that are being paid and to the salary. If your department could give us some insight as to how we're going to address that workforce shortage going forward, and to see what your thinking might be on how we adjust with the payments, I would appreciate that.
Thank you.
Thank you.
All set, Representative? You're welcome. Representative Exum.
Good afternoon. Good to see you, Commissioner. I just have a question as a follow-up around the IQ piece. This is something that has been a part of discussions in which I've been involved for quite some time. And so I'm happy to see us talking about it more. I think that from what I'm understanding, most states do not look at a hard score anymore around that 69 number. And I'm wondering what types of discussions are there really as far as looking more at functionality, what people actually may be able to need, because that number is arbitrary. There's not a big difference between 86, 71. Sometimes the score does not necessarily reflect the individual elements and abilities that someone can have, what they're able to do, and it limits what they're able to access. When you're right over that line, you may still need supports. The supports could look different. So I'm curious about what has been done to look at what most of the country may be doing in this particular area.
So thank you for the question. We can bring some information. When I heard the discussion starting at the beginning of this fall around eligibility concerns, I reached out. I'm on the board for NASDs, which is the National Trade Organization for people who do what I do. So we have some comparative, like some ideas about the states that have abandoned IQ testing and those that have continued it. And I can get information from NASDs to give you that federal perspective. So it won't be my look around the country. It'll be there's a trades organization look around the country. And we can start to have that conversation in earnest. And again, understand and I appreciate Senator Dawson just wants to take care of everybody and then has to balance that with her roles with the fiscal responsibility, but wants to know what the universe is for people who might need help. And so we can try, and I think that the DD Council has a better understanding based on the work that they've done as to what the numbers of people who might be eligible and the types of supports they might be needed if you were to consider changing the eligibility statute. But we've been talking, and I'm happy to talk with you and others more on that issue, and we can provide some information.
I think that would be really helpful. I think that we need to look at this differently. I look at a waiver and I understand there's a certain amount of money per person, and we have this line of people who waited for a very long time who will not get what they need for a long time. But does everyone need exactly the same thing? What does that really look like? And I think readdressing this in its totality, there may be a different way to look at the way we're delivering services. And I know it's not like you've not thought of this before. I recognize that, but this has been a part of a world in which I've lived for a long time. And I've seen the way that the state has moved throughout this process. And I know the need that's out there. I also see things that happen, for instance, when there's someone who comes from another state who moved here with military, they don't have a waiting list. They come here and they're at the back of the line, and their family was moved and they have no choice. They're serving our country. How do we don't have any flexibility around certain things like that as well. So I think, again, this is an area that really needs to be deeply assessed.
Thank you. We have some capacity, and the agency has made some decisions around military families in particular, given their service to country, and considered state funding versus federal funding for some individuals in those circumstances, although it's been a couple of years or more since I remember being asked to consider such an exception. I can also tell you there was a time where states were more open to interstate compacts that would allow us to do things differently. And that goes back more than 20 years to when I was in Rhode Island. We actively had 3 or 4 interstate compacts, and that allowed people, especially in New England, where all the borders are so close, to do things a little differently. But we don't have any currently, and that may be another avenue to try and solve the problem that you brought forward today.
I think that's a really good idea. I know we did some of that last year in 5001 with the Children's Behavioral and Mental Health Bill, where we were able to have more flexibility with our neighboring states. It allowed us an opportunity. So certainly that could be definitely something else to consider. And I also am concerned when there are individuals who are right there on that line. And what I've been told is that they may not qualify for services, but they also are not permitted to get any help through BRS because they're not quite where they need to be there. So they're stuck. And it's a number that kind of sometimes can keep them in that place.
And our friends in the autism community suffer from sort of the flip side of that, where their IQs are often very, very high.
Yes.
But their needs are great, but it's hard to measure their needs strictly by their IQ when it comes to performing or certain daily tasks. So it is an interesting question. It's one that over the last few years, I've been focused really on health and safety around COVID and some system transformation to create capacity, to reduce the wait list and those types of things. So it's a conversation I'm not really immersed in yet, but it sounds like I will be pretty shortly. And I look forward to engaging with you on that very subject.
Thank you. Thank you so much. And I look forward to the work groups.
Thank you, Representative Dayton.
Thank you very much. And thank you, Tammy, for bringing up, Representative Exum for bringing up that point. It's something I've been thinking about in every waking moment of mine when I'm not driving up and down to the Capitol, but thinking a lot about what we're doing in our state compared to other states. As you know, we've talked about the arbitrary number of 69 can be different and how that really affects. And I know a lot of our neighboring states don't have that. They really focus in on the lawn or the level of need of the individual, which, as you point out, some people in the autism spectrum who, I've reached out, I heard from a woman whose son has, like, I think it was 142 IQ, but has difficulty feeding himself, getting dressed, the daily tasks. And she's really concerned that her 26-year-old son is not receiving the services he really needs, and what's going to happen to him as the parents age and how he will be taken care of. So I am very keen on having those discussions with you as well. And it's something I'm thinking a lot about. And I'm hoping to hear from families in the next week with all of our public hearings that we have going on in this subject. So thank you for being open to those conversations. My question really is about the ARPA Home and Community-Based Service Reinvestment Plan. I'm not sure if you know the answers to hand, but there was 52 million in the community residential services. And I just wanted to get an update on these funds that were provided in the general fund in fiscal year 23, which included new supportive housing units. If we can get maybe a list of the providers and the funds that have been received so far, and just want to try to understand how we are, how that's kind of coming along. And then my next question, just wanted to understand how we are supporting our nonprofits here in our budget that provide 95% of the services. Want to make sure, we are taking care of them because they take care of our safety net, and would love to hear how we're doing that in this budget. So those are the two questions I have. You can either answer today or bring to the work group.
That's more than I can answer off the top of my head today, where I have prepared in front of me with regards to the ARPA spending. So we will follow up with that. When I was talking to Representative Axum about eligibility, I should have noted my new deputy commissioner who's with me today, Elisa Velardo, is also the past president of AAIDD, American Association for Intellectual and Developmental Disabilities. And they have some white paper type stuff on eligibility in their look federally in state comparison. So with regards to that conversation, we have resources we can bring.
If you can share that
so that
earlier
you don't
rather
have to
than
reinvent the
later,
wheel.
if that's easy to share, if you can share it earlier rather than later, I have a few minutes this weekend that I could have a look at. I would appreciate it. I know.
Yeah, we'll see if we can get the AIDD stuff over to you with published information as
Yeah.
quickly as we can. And I'll see if there's anything proprietary about the NASD's information and my release of that.
Yeah, I had a poke around their website when I was trying to figure out that. And that's when I found out about the work programs that you all are doing for folks in this community, which is a
SELM
great,
program.
it's SELM.
Yeah, Supported Employment Leadership Network.
It's fantastic. So I'm really pleased that you all are embracing that as well. So, but sorry, I've cut you off.
No,
Thank you.
that's all I had to share on that.
Awesome.
I
Thank you
don't
so
have the-
much, Commissioner, and appreciate your testimony today. Thank you,
Thank
Madam
you.
Chair.
Thank you. Are there any other comments or questions? Seeing none, Commissioner, we have a lot of work to do, so we look forward to all that information. I think you have a whole,
It was 15 pages. I woke up to 15 pages of statute. We're working through that and are ready to engage fully. I know it's busy, but we're going to commit all our resources to partnering with you on exploring all of that.
thank you very much. Have a nice day.
You too. Thank you.
Everybody will be back at 1:30. We'll recess until then.
So I'm thinking, if you're agreeing with me, that
Hi. Okay. Hi, Commissioner. You all set? Hi, Commissioner. Can you hear me?
Yes, I can. Nice to see you, Senator.
Nice to see you. How are you feeling?
I continue my recovery, a little bit slower than I had anticipated, but getting better each day.
All right, well, we're happy about that.
Thank you.
So that we're, obviously, this is the Appropriations Committee health state agency presentations, and we're on the Department of Veterans Affairs. And we have Commissioner Sadi here with us, and Commissioner, the floor is yours, and then we'll have questions.
Thank you very much, Senator, and esteemed members of the Appropriations Health Subcommittee. I really appreciate the opportunity to have submitted my testimony and now to appear before you to speak about the Department of Veterans Affairs, we refer to as the DVA, and the governor's proposed budget. The mission of the DVA is serving those who served. And as I often say, with those 4 simple words comes a great responsibility. As we know, it is because of those who served and those who continue to serve in our armed forces that we're able to live in our great state and our great nation in a free and democratic nation. So I first want to thank our veterans and current service members across our state and our nation for their service and sacrifice. At the department, we continue to update programs, procedures, and our physical facilities to improve the delivery of long-term skilled nursing care, of residential and rehabilitative services, benefits advocacy and assistance, and cemetery and memorial services to our veterans and service members. We've accomplished this in some very challenging times, particularly throughout the COVID-19 pandemic, due to the exceptional hard work of the DVA staff. Also, great partnerships with the federal VA, support from other state agencies, in particular, the Connecticut National Guard under the military department. Since I testified before this subcommittee in 2001 on fiscal year budgets 2022 and 2023, the DVA has successfully completed extensive quality of life renovations and improvements to all our veteran rooms in the residential facility. And also repairs and repainting were completed throughout the facility. We established a new creative arts workroom, installed new computers in the veterans computer and game room, initiated renovations that are ongoing to our veterans library. The DVA also installed new outdoor recreation pavilions in the residential facility and healthcare center. These projects were accomplished through well-planned targeted use of donation funds and other internal resources. The DVA has also implemented operational and policy updates to make admission processes to our healthcare center and skilled nursing facility more efficient through greater coordination between DVA staff and the Department of Social Services in the tracking of Medicaid applications, and actively engaging with families of persons assisting veterans in the Title 19 application process. We also continue an energy efficiency program, which among other things will help to hopefully stabilize utility costs and includes updated lighting controls, new refrigeration, and transition to efficient LED lighting and solar lighting options as appropriate. We continue to expand our partnership with federal, state, and local agencies and nonprofits, and with our statewide veteran service organizations to pool resources, coordinate efforts, and expand supportive services for veterans. Doing this allows us to act as a force multiplier and to reach out to more veterans across our state. Several organizations as part of this process have located their operations to our newly renovated Veteran Resource Service Center on our campus, which is moving us towards the goal of making the DVA campus more of a one-stop hub for veterans. These types of partnerships include those with Easter Seals Veterans Rally Point, who are also expanded to provide their services at our campus to community-based and our campus veterans at no additional cost to the state. The governor's proposed biannual budget enables the DVA to continue improving our services and delivery of our services through fiscal years 24 and 25, with continued structural adjustments to expenditures from the DVA's Institutional General Welfare Fund in order to ensure that that fund remains stable and solvent for the long term. I thank you for your time, your service to our state, and I'm glad to respond to any questions that you may have.
Thank you very much, Commissioner. Can you tell us what is the first, I'm gonna ask the normal question we ask. We see that you have 239 staff or positions that are agency requested, and how many of those are filled positions and how many are vacant?
200. We have 15 vacancies of the 244 of the full-time number. You guys, excuse me, medication dries my throat a little bit. We currently have 15 vacancies.
And do you have federal positions that you oversee also within the Department of Veterans Affairs?
We do not have federal positions under the department. We do have, via memorandums of understanding with federal VA, 2 federal clinical providers, psychiatrists that provide services at our campus. Those are fully funded and paid for on an annual basis, renewable with federal VA.
Are they able to, the psychiatrists that you have, do they service just inpatient or do they service in outpatient veterans?
The MOU and the limit pursuant to the federal regulations with regard to state veterans homes, those MOUs provide those services for our veterans on campus solely. They don't provide it to community-based veterans. That is solely for those who are in our care at DVA.
And how many people are in your care now?
Currently, our census on the residential side, I believe today, it's a moving count, is 106. But we also have approximately 10 family members that are living with veterans in our family housing program, as well as 85 veterans in our skilled nursing facility.
So you take care of quite a lot of veterans.
Approximately 200 on our campus at any one time. That does not also include Veterans Rally Point, which has, I believe, 11 veterans in their program. That is part of a memorandum of understanding with DVA. So at any one time, we probably have about 210 to 220 veterans in our direct or indirect care on our campus.
Well, thank you very much for that. Relative to the SSMF, where do we stand on the SSMF, the Soldiers and Sailors Fund?
Yes, so the Soldier Sailor Marine Fund is a pass-through appropriated item where the money comes to DVA and then we provide the money for their operations directly to the American Legion. We do that on an ongoing basis throughout the year, pursuant to also receiving audited reports that come to the DVA. That, my understanding, is fully funded. And again, it's not something we oversee. We are a pass-through agency for the Soldier Sailor Marine Fund.
Thank you. And then the last one that is relative to burial expenses and headstones. The burial expenses, are they the burial expenses on the veteran cemetery? Is that what that is for? Can you explain?
No,
that?
actually, Senator, the burial expense line item there are for the indigent burials that when we receive applications and review them and determine eligibility. And the headstone is a reimbursement for installation of headstones in community-based cemeteries for veterans. And we have increased that over the last 2 years significantly. It had been stagnant for a long time. Our costs for burial and operation of our state veteran cemetery in Middletown is included within PS for our full-time employees, as well as OE, other expenses for the other items that need to be purchased for the cemetery. There is no separate appropriated line item for cemetery operations. And Senator, I apologize. I did miss something, and I want to introduce, I have members of my staff here. If I may, without objection, just take a moment to introduce who is also in the meeting.
Please go ahead, sir.
Our Chief of Fiscal Operations, Ms. Brianna Mitchell, is with us today to respond to any questions. From her staff, one of her senior fiscal analysts, Helen Chan. Also, our Director of Operations at our facility, Mr. Joseph Mayo. And our staff attorney, Jane Siegel. The reason our staff attorney is on is I currently don't have a legislative liaison, and she is fulfilling that role, being dual-hatted. So I thank you for allowing me to introduce them.
Anytime. And I have questions from Representative Nolan.
Good afternoon, sir. How are you today? And to your staff, thank you for being here.
Thank you, sir.
You talked about your 15 vacancies. could we get a list of those vacancies that you have, what the positions are? And also, is there something in the process to fill them? Is there anybody waiting to get on board that you have, or how long have those 15 vacancies been vacant?
Thank you for the question, Representative. Yes, we can absolutely get you a list. It's, again, a snapshot of a point in time because it's constantly a moving target. And with regard to how long, we are actively following and working through the HR centralized posting and hiring and onboarding system. While there was a little bit of a slow start when centralization began, we are now moving at a fairly good pace with filling our vacancies. So it's not that we have a set number of 15 or 20 vacancies and those aren't being filled. You have people leave through retirement, they take other jobs, something may occur and they go out on leave. And so we are regularly filling positions at that time. So we'll get you that point in time as of today, what that vacancy looks like. And every week, our HR department goes through and provides me a snapshot of where all our vacancies are in the recruitment process, from proposing it to posting to certified list to interviews and hiring. So we keep close track of that. I will say probably our largest number of vacancies, for reasons that many people know, are on the clinical side. So we are working very actively there, as well as supporting efforts to do more rapid onboarding of clinicians in the healthcare industry.
Oh, thank you, sir. And another question would be, you talked about community-based cemeteries. Can you explain that a little bit? And is it, is that mean private cemeteries, or is that different than the regular veterans?
So the Department of Veterans Affairs, we oversee 3 cemeteries. Our State Veteran Cemetery in Middletown, which is a federally recognized, and we receive federal grants for capital improvements, which we've done at that cemetery to a great extent over the last 3 or 4 years. Darien, which was a state veteran cemetery that reached capacity in 1980. We work at, we just maintain that, but it's not a cemetery accepting burials. And Colonel Gates Cemetery, which is across the street from the Department of Veterans Affairs, which is limited to those veterans who pass while they're in our care. So those are the only 3 cemeteries that we have jurisdiction over. The reimbursement for headstones, that line item is to reimburse families for the installation of headstones for veterans in community-based cemeteries. They apply to us for that reimbursement. We process the application, and then that reimbursement is dispersed to them. The department has no jurisdiction over the care or oversight of veteran burials outside of the 3 veteran cemeteries that I described: Darien State Veteran Cemetery in Middletown and Colonel Gates in Rocky Hill as part of our campus.
Thank you, sir. And just to follow up on that, there's been a lot of complaints in regards to cemeteries where some of our veterans' graves are either sunk in the ground or there is some kind of overgrowth on them that has damaged the actual plot that the person is on. Is that funding that would help with that? Not the upkeep of it, but the replacement of something?
No, sorry, Representative. No, there is not. And in fact, candidly, I don't support the Department of Veterans Affairs becoming involved in policing or maintaining veterans' graves and their care in community-based cemeteries for multiple reasons. The first being that the issues that affect veterans' plots not being upkept in a community-based cemetery most likely affect all the plots or many plots in that cemetery. So it's actually a cemetery issue. It's not a veteran issue. And also, we don't have the jurisdiction to go into there and to do that. There is a responsibility on cemetery associations and ecclesiastical organizations to maintain cemeteries, and the statutory authority for that should be utilized. If changes need to be made to the law to give more authority for some agency to do those things, then that's what would need to be looked at. And obviously, the appropriate staffing and funding would have to follow any changes in the law.
Okay. And if I could move on to transportation in regards to our veterans that need transportation to your facility. And if they can't get transportation to your facility, is there something that covers them in the town that they're in, with a private doctor or something inside, like Shaw's Cove in New London has a VA facility, but they don't have a doctor there.
So, Representative, with regard to our facility, for our veterans on our campus that are in our care, we provide the transportation to their medical appointments within the community as well as at the federal VA, West Haven, and in Newington. For community-based veterans, we do not provide, nor do we have the staff, appropriations, or even the statutory authority to provide community-based transportation to community-based veterans. We work with DAV, Disabled American Veterans, a host of other community-based providers, senior centers, Department of Transportation, local municipal transportation supportive services. And in fact, a couple of years ago, our agency put together a roll-up list of those services and sent them to the Veterans Affairs Committee because of this very issue. The problem here is that those types of services are not necessarily consistent across the state. And the more rural someone is, oftentimes the more difficult it is. But the issue of transportation would need to be looked at more comprehensively. I opposed in the past the DVA doing that without being given an entire transportation division. That's what would be required. So I believe at a community-based level, coordination can help a lot. And maybe working with our municipal officials to help coordinate through senior centers, through departments of social services at the municipal level, and through municipal vet reps and veterans directors at the municipal level to just aggregate the information on transportation services. And I'm happy to send you that list that we put together. It may be a little dated, but at least it's a starting point.
Yeah, if you could send that, that would be appreciated. If you could send it to the clerk, and they'll give it out to everyone.
Absolutely, Representative. Thank you.
And my final question is going to be, you talked earlier about how many residents that you had in between your skilled nursing, your regular residential, and your family, the housing that you have. And then you said Veterans Rally Point. Can you explain the difference between the Veterans Rally Point, the family housing that you have a little bit across the street, I think?
Absolutely. Very, very good question, Representative. So Veterans Rally Point is a division of Easter Seals. And they are a community-based nonprofit. And Veterans Rally Point on our campus is there on our campus pursuant to a lease with the Department of Administrative Services and a memorandum of understanding with the agency. They provide short-term, more shelter type of housing, but it's not exactly that. But they can admit somebody very rapidly, have them there for a short period of time, and then if needed, transition to our residential facility or to our skilled nursing facility, or go back out to the community. So it helps us to address an immediate need because pursuant to statute and regulation, for admission to our facility, our residential program at DVA and skilled nursing, it's an application process. So we partnered with Rally Point to have that bridge. And some of those veterans will come to us. Others will complete their treatment or their supportive services at Veterans Rally Point and return back to the community. So also, Veterans Rally Point offers a multitude of programs and supportive services, discussion groups, vocational and educational services that are available to our residential veterans at no cost to the state. So it's an additional service that we can provide to our veteran residents on campus without any additional cost.
Okay, well, thank you for those questions. And actually, I'm sorry, I have one more. You talked about a transportation division. Did you say that came up prior in regards to maybe the numbers of what that would cost? And
I apologize, Representative. I'm having a little difficulty hearing you. Could you please repeat the question, sir?
You mentioned earlier about a possible, well, I mentioned earlier about transportation, and you said that in order for that to happen, you would need to have a transportation division. So I was wondering, did that come up in a previous legislation or time where there's numbers that showed at that time what that would cost and how it would happen?
Yes. There was a bill that proposed to mandate that the Department of Veterans Affairs Office of Advocacy and Assistance provide transportation to community-based veterans to doctor's appointments and to interviews for employment. And in my testimony, I did oppose that. And it said within existing appropriations or within available appropriations. Impossibility within available or existing. So I did put together testimony and we did put some numbers together. There was not an extrapolation as to the dollar cost, but you could possibly extrapolate that from the vehicle needs that would be required, the transportation, the coordination, the staff. I'm more than happy to send you that testimony. Again, it may be a little dated, but it was at least to the main point.
Yes, if you could, I'd appreciate that. Obviously not this year, but maybe in the future we can look at something that would help benefit our veterans in regards to transportation, because I know that's important to a lot of our veterans. Thank you for all you do. Appreciate your service. And Madam Chair, I'm all set.
Thank you, sir.
Are there any other questions? Representative Delaney.
Thank you, Madam Chair. Afternoon, Commissioner Sadi. It is a pleasure to see you, sir.
You as well, Representative.
I just wanted to start off by thanking you for being here today and to thank you for the work of your good staff. It's a pleasure to see you guys here as well. To me, one of the most forward-facing elements of the DVA is our Office of Advocacy and Assistance and the Veteran Service Officers. Could you, for my committee members, break down some of what they do, our office, our VSOs, and the importance of that program?
Absolutely. And thank you for the kind words of support for the staff at the DVA and all the hard work that they do. Our Office of Advocacy and Assistance is that very public face of the agency. We have 5 district offices, and they are staffed by veteran service officers, known as VSOs, not to be confused with veteran service organizations, also known as VSOs. But our veteran service officers are certified to represent veterans in filing their claims for benefits with the federal VA, whether it's on the pension and benefit side or the healthcare side. These veteran service officers also assist veterans and eligible dependents in engaging with state-based benefits and programs and services, as well as municipal programs and services. They are across the state in our 5 district offices, go out to skilled nursing facilities, senior centers, veterans halls, engage with the local community at vendor and benefit fairs, as well as work, as some of you may know, with legislators when you're holding outreach programs and services in your respective districts. The veteran service officers and the OA&A office over the years had been somewhat attrited or shrunk down. And so over the last year, we've been successful at adding additional veteran service officers with the goal in the next 3 months to be at 10, 2 in each district. At one time, we were down to 7, 10 with 2 in each district, men and women, all combat veterans, more than one being multilingual, as well as having an administrative support staff in each of them. So 3 people assigned to each district, overseen by our manager of advocacy and assistance, Mr. John Carragher, at our main campus. It is also important to know that these VSOs are also part of that communication chain with our municipal vet reps. They don't oversee them, but they are often the ones that take calls from legislators, from local municipal officials to answer their questions and to guide veterans to where they need to go. We have also relocated we're relocating one of our offices in order to better serve our veterans, so we can have better parking, walking into the office, more foot traffic, and also places to meet that are more conducive both for maybe group discussions and small confidential meetings as may be appropriate. So some of you may hear we have relocated now from Bridgeport to Fairfield. We did that in collaboration and cooperation with the municipal government Fairfield, as well as with Mayor Ganem's office at Bridgeport. There is no break in service to anyone, and we think we'll better serve the community in that area. So I appreciate that question, because the Office of Advocacy and Assistance is incredibly important. It also oversees our cemetery and memorial services staff, not the physical staff that take care of the cemetery, but the ones that receive the applications and schedule and oversee final burial rites for our veterans in Middletown. So that's another important aspect of the Office of Advocacy and Assistance.
Thank you for the answer, sir. I know that I myself, other veterans in my community, and those veterans' families consider the VSO heroes and the program invaluable. And while my colleagues and I most certainly, take advantage of this program and refer veterans in need to it, could you just break down a little bit again how the average citizen would, or average veteran would get in contact with the VSO at the ground level?
Right on our website is the link, the email, as well as the phone number to each of our 5 district offices, as well as the main office. Also, just by coincidence, this week and next week, we are doing a mass blast email out to veterans community, municipal vet reps, legislators, our board of trustees, with the links to our website, as well as what we call our one read sheet, a brochure which contains information about our 4 function areas and details of how to contact the Office of Advocacy and Assistance. One thing, of course, if anyone has a problem reaching the Office of Advocacy and Assistance, always just call my office, which is 860-616-3684. And we will make sure that a VSO or a manager of advocacy and assistance reaches out to that veteran or family member.
Thank you, Commissioner Sadi, sir. And my final question is for our bilingual constituents, anyone who's looking to get aid, are there any provisions made for them when they reach out to the Office of Advocacy and Assistance to get in contact with a VSO?
Yes, we do have multiple bilingual VSOs. Now, they don't speak every language. It is English and Spanish mostly, but we do have some people on our campus that do speak other languages, either as English as a second language, or they do speak that other language as a second language. But if we do have an issue, we would reach out and try to find a veteran who could provide us with those interpretation services. In my tenure, I don't believe we've run into a problem where we have not been able to engage actively with a veteran because of a language barrier. We either had somebody in our staff or the assistance of a community-based organization that could provide any translation services needed.
Thank you, Commissioner Sadi, sir. And I just like to take a second to say, one, thank you for your service. The veterans in my community and my colleagues and I consider the work that you do as invaluable, that your VSOs are heroes, and that we are very, very lucky to have you doing the good work that you're doing. So thank you, sir.
Thank you so much for your service to state and our country, Representative.
Roger that.
Thank you. Next is Pat Dillon. Representative Dillon.
Thank you, Madam Chair. Good afternoon, Commissioner. It's great to see you. You're looking pretty well. I want to thank you for the improvements that have been made to your department because of your own vision. And I know sometimes it was bumpy getting there, but I think you've really gotten to a good place, and I want to thank you for that.
Thank you, Representative.
I do, however, quickly, while I'm thinking of it, want to thank Representative Delaney for mentioning the VSOs and request that the exchange that you're having be provided to the work group, and that documents be available to committee members. I know we could tell them to look on your website, but sometimes it's better if we have a document that refers people there, or that tells them where they can go, because it's a really, really good point. So that would be really helpful if you could send it to the work group. The second is, again, for the work group, it would be to ask if you could summarize very briefly your relationship with the military department, which you referenced in your testimony. And then the third would be the service from your department or the outreach or representation of women veterans.
Thank you, Representative. Nice to see you as well, and thank you for the kind words. We will send to the work group that an email which contains the links as well as a copy of that brochure. That is our sort of one sheet read that we send out. So in fact, what we planned on doing was sending it to the VA committee, but I'll expand that. I think it probably makes sense actually to send it to every legislator. But I don't want to be, I don't want to be that person that is trying to, that people think there's some ulterior motive to sending something out. So based on this request and this conversation, we will now email out to the members of the General Assembly. With regard to the military department, under the leadership of currently General Yvonne, we worked very close throughout the pandemic. They provided us with supplemental staffing, medics, known as 68 Whiskeys or 68 WMOS, who are on our campus for many months, who are providing us with the ability to screen our veterans on a regular basis, as well as to support our veterans as they may have been put in isolation when they contracted COVID or were under isolation because of quarantine because they were exposed. That dynamic was excellent. Beyond the actual clinical work that the military department members did, it was the connection between these young soldiers, men and women, who are now engaging with veterans 20, 30, 40 years older than them, having great conversations and sharing stories. So it was a great experience. But also with the military department, the close relationship is getting services to veterans when they're redeploying, coming back from deployments, making sure that we have our Office of Advocacy and Assistance represented at those yellow ribbon events, as well as any issues that soldiers or air personnel are having within the military department. We can provide services that the military department may not have or help them get connected with the federal VA. And then also just recognizing veterans. It may not seem to some people that important, but I think you understand it as ceremonies and recognition and remembrance is incredibly important.
Yes.
And we engage and partner with the military department, Connecticut National Guard, to do that. They support our events, we support theirs, and together we support events in the community. And that often is a conduit to getting information out about programs and services at those ceremonies. So I hope that answers your question. And, again, I cannot thank the military department enough for how much they've done, I'm not, for us at the DVA, but also the state, particularly through the pandemic. And then your final question with regard to women veterans. Well, I'm very proud in our Office of Advocacy and Assistance and our BSOs, the number of women veterans we have, and also applicants who are coming through for those positions. Outreach to women veterans, we had started a fairly robust program before the pandemic, and we had multiple veteran women events around the state where we were actively engaged in bringing them together. Candidly, that did fall to the wayside a bit because we weren't having these larger events.
Right.
We're restarting that and looking this year to start that again, doing a women's veterans event just to bring them together across the state, but also highlighting the work of our female staff and women veterans on our Board of Trustees, which have expanded over the last few years. We recently had for the first time a vice chair of our Board of Trustees as a female veteran, although for work reasons, she had to resign, but we're going to have other people joining our Board of Trustees. So it's a work in progress. More needs to be done because the fastest growing demographic within the military and now veteran community are women, even though they currently only make up about 11% of all veterans. So the number will grow and we have to adjust with that. And finally, what I will say is working with federal VA, and the federal VA has expanded programs focusing on issues that women veterans deal with, and we partner with them. And one of those things, we talked about family housing, and I apologize, one more thing. We're looking at expanding our family housing program. And the reason being is that as there are more female veterans, let's be candid, there are more female veterans who are head of household, and they may have minor children. And so a communal living environment for one veteran, living in a room does not make sense to be able to provide services for the broader veterans community. So we're looking at possibilities of expanding Patriots Landing, which is our family housing program, which indirectly, I think, supports women veterans in need.
Thank you. And I wonder, I just want to repeat, if you could provide all of this information to the work group and we're all busy today. There are multiple things going on, and I know people would want to know what you're doing and would be excited to support you. Thank you very much.
Thank you, Representative.
Thank you. Any other questions? I believe that Representative Nolan has one more question and then we'll move on.
Thank you for that one more question, and
Walk loudly into your mic.
thank you for the final question. And I'm sorry but I was looking at some notes from prior, and I forgot to ask how you're involved with Office of Early Childhood and the Judicial Department with families or any related issues. How could you explain how you might be involved with them?
So I'll start with the Judicial Department because it's a very specific involvement, and then go to the broader one with early childhood development and referrals. We provide the review for individuals who are applying for programs that are for veterans through the Judicial Department, whether it's accelerated rehabilitation, pretrial diversionary programs, or other supportive programs. So the DVA does the analysis of the paperwork and sends a certification notice to judicial, to adult probation, whoever it may be, saying this person is an eligible veteran for that purpose. But beyond that, we also take referrals. And just be candid, there are individuals that we care for who do have criminal records. And so, but they are entitled to those veterans benefits that they earn through their honorable service. So we do have referrals over to residential programs or to other programs that we provide, or we refer them to the federal VA if they're federal VA eligible. We also work with DOC. If there is a veteran coming out of corrections and they need housing, we receive referrals. And what we try to do is review the application before the veteran is discharged from DOC so that their transition is seamless and they're not hypothetically or potentially homeless in the community before they come to us. That began about 5 or 6 years ago. We had several working groups with the Department of Corrections, and so that continues. With regard to early childhood development and the other agency, we do receive referrals for supportive services. We do not have a specific relationship with early childhood development or a particular dynamic, except a informal interaction when they have a veteran in need and ask us if this is something that we could take on, or do we know of programs and services that could support that particular client.
Thank you, sir. I do not dare to ask a question for that answer that you gave me. So I will connect with you and Brianna at another time. Thank you all for all the answers that you gave today. We appreciate you and your service.
Thank you, Commissioner. There are no other questions. We appreciate it. And we might have you come to a work group to talk about a couple of other things. Thanks.
Thank you. Thank you.
Up next is the Office of the Chief Medical Examiner, Dr. Gill.
Good afternoon. My name is
I can't hear you. I'm sorry. Do we know what's going on? Dr. Gill, we can't hear you. James, what's going on?
Madam Chair, I think it's on Dr. Gill's side. I think it's his connection. As you heard, he started and then
I know
his audio cut out, and I'm not sure why.
I see him talking, but I don't see him. We can't hear him, and I don't think he can hear us. Yes. I don't know. He went away. We can't hear you. Can somebody call him and let him know that we can't hear him? Is he still talking? He is. We just can't hear him. Dr. Gill, we cannot hear you. You're making great testimony, but we can't hear you. Don't think you can hear us, but we cannot hear you. Hello. Yeah, no, but does anybody have his phone number to call him?
I'm going to call the office.
Thank you. Dr. Gill had some money too. Well, we can't even ask him any questions. He and I are not talking, as you can see, there's no talking going on. There is talking going on because he's not stopped at all.
Are you holding up a
He is. Can't hear you. Cannot hear you.
He's looking.
He's looking.
I think. We can't hear you. She just handed him a note. Yeah.
You guys laugh at me all the time.
Can you hear us now? Can you turn that up? We cannot hear you. We can't hear you. No hearing going on.
Can you hear us now?
Yes, I can hear you now.
Should I start from the beginning?
Yes, you have to start from the beginning, Dr. Gill, because we did not hear a word you were saying.
All right.
I
So,
just want to tell you, we did say that you were doing wonderful testimony, but we could not hear you. So go ahead.
okay. Yes, we're good. So yeah, my name is Jim Gill. I'm the Chief Medical Examiner, and I'm here with Dr. Maura DeJoseph, the Deputy Chief Medical Examiner, and Dwayne Gordon, our Chief Administrator. So we continue to see an increase in death investigations, and we have some charts and tables in our testimony to show that. Our investigations are labor intensive. They occur at unpredictable times and locations, and are increasing with all impacts all aspects of our day-to-day operations. Fiscally, this translates into more costs for transportation and storage of remains, laboratory testing and supplies, including toxicology and histology testing, and on the personnel line, costs for overtime and nights, weekend, and holiday coverage. With the use of intermittent grants, some new efficiencies, and per diem staff, we have worked to meet these challenges administratively in order to perform high quality and timely death investigations. Our accreditation status also hinges on having the appropriate number of medical examiner physicians to handle the volume of autopsies to be performed. NAME, which is the National Association of Medical Examiners, has recommended that we be staffed with one additional medical examiner, which would allow for improved turnaround times and for our autopsy reports, and death certifications. Obviously, we need a budget that fully funds our personnel expenses with added support to differential pay and overtime, and a budget that fully covers our operating expenses for an increasing and unpredictable number of investigations. Thank you for your support and the opportunity to address the committee. I'm available to answer any questions.
Thank you, Dr. Gill, and so sorry about our little complications earlier. You have a number of positions that are in your of 63, and then the governor added another position in there. How many people do you have working for you right now, and how many vacancies do you have?
Wayne?
I believe the full-time, you're talking about the full-time equivalent, full-time?
Correct.
I believe we have 52 filled, and I believe that there are 9 vacancies.
And I would say that 2 of those vacancies are actually medical examiners, which there's a national shortage of medical examiners. It's very difficult to recruit forensic pathologists who act as the medical examiner. And so that's been a challenge for us to fill those positions, actually.
The names of the people that you have with you, could you just repeat and spell them so that our staff can include them in the minutes?
Sure. Dr. Maura DeJoseph, DeJoseph, and Dr. Dwayne Gordon, Gordon.
Thank you. Thanks. And so the medical, forensic pathologists, do we pay them enough in the state of Connecticut to hire them, or is the shortage just as a result of the national shortage?
Yeah, I think it's a combination. Seeing across the country, many offices are short staffed, and so that's driving up the salaries. And so it has become very competitive. There are, starting positions around the country higher than ours. And so that is a factor. I don't think it's the only factor, but I think if we had a little higher salary, we'd certainly be able to, I think, get more candidates interested in our positions.
And you had said that the numbers are continuing to go up. Is that the numbers of those that are dying as a result of fentanyl overdoses or other overdoses?
Certainly, it's the drug intoxication plays a large role in these deaths. Last year we had over 1,500, or 2 years ago over 1,500 accidental drug intoxication deaths. The numbers for this past year, 22, are not quite finished yet, but I suspect it's going to be similar, maybe a little bit lower actually, but similar. And those again are, that for 1,500 autopsies. You're looking at, just for a medical examiner staff, you would need 6 medical examiners just to do those autopsies.
And do you see the numbers, do you do the autopsies relative to gun violence? Do you see that number increasing if you do those?
The homicides have been somewhat steady. They've increased from the last few years. But we also see gun violence with suicides as well. Firearm deaths, suicides using firearms is probably the most common cause of death in suicide. So, and all of those violent deaths, all homicide, suicide accidents, they all get reported to our office. And by statute, we have to investigate all of them.
All right. Well, thank you very much, Doctor. We appreciate the work that you do. We know it's hard, and we want to make sure that you have the correct number of staff. So we'll be looking at your personnel numbers pretty closely. We may come back to you with a couple of questions. I do have a couple of other people that have questions. Representative Dillon.
Thank you, Madam Chair, and thank you, Commissioner. I wonder, just a couple of personnel matters. I believe we recommended at your suggestion that 2 part-time positions that were non-clinical be converted to full-time. Did that happen?
That would be photographer.
And an IT.
In an
was the
IT,
last-
yes, we did. So we needed more photography support in the autopsy room. So one of those part-times became full-time, and then we only had 1 full-time IT person, so the other part-time IT person also became full-time. Yes, so both of those occurred.
And so I wonder, and I really should ask you to send this to the work group to respect everyone else's time. There had been a lot of discussion over the years about difficulty in recruiting because of our own salary structure, if you recall. So it's disheartening, but not surprising that now there's a national as well. And so if any other information you could provide for us would be really helpful. On the drug overdose, did the testimony you provided on the charts give a geographic distribution of where those deaths are? And if not, could you provide them?
Yes, actually, we put it on our website. So there's a listing of every death and town, location, and the actual intoxications. So we do that every year.
Is there a map, or is it a list of numbers?
It's a list of, it's a spreadsheet of all the deaths. And so you can sort it by town if you want. I believe that there is a group in Hartford that actually puts it on a map as well.
That's very helpful. Actually, and on the suicide, I'm sure this is stale now, but it used to be that the highest suicide risk was white male, advancing age. That is, I mean, there was a linear relationship. Is there a pattern now in terms of suicides? And I guess I'm excluding fentanyl because some of those are accidental, maybe, I don't know, but I'm thinking of the shotguns by firearm, I mean.
Right. Yeah, no, I think, elderly white men are still at greatest risk for suicide in Connecticut. And the common methods are firearms and hangings. would be the common methods.
But you would be doing an investigation because it was unexpected, is that true?
Unexpected and unnatural, yes. So any death that's unnatural due to an injury, yet we have to investigate, correct?
Okay, well, thank you very much for the work that you do. I know we try to keep up with what you need, but it's not easy. And so if you could provide the work group with any other information about, let's say if we need another position, to keep certified, I don't know how heavy a lift that is, but that sounds very important. Thank you very much.
Thank you.
Next is Representative Walker.
Good afternoon, sir, and thank you for testifying before us. I just want to know, did you get any ARPA money last year for your department?
Yes, we did. My name is Dwayne Gordon. We did.
What was it
For
for and
this-
how much?
I don't have the figure for last year. I can send that through OFA if you wish.
Okay, all right. I just, did you receive the money from ARPA?
Yes, and we are currently for fiscal 23, we do have money. The appropriation is for 2.5 years. The amount of money for the current year, Representative, is around $333,000. I can also provide that detail.
Okay, was that for the 2 examiners? Was that what-
No, we do not have any personnel in our request. In our request was as best we could to narrowly project what we needed for resources. So for instance, our refrigerated trailers, our additional C box because of lack of storage. So it's those types of things, a laundry list, Representative, for our PPE requirements for the additional work that we've been doing, things of that nature. If you want a breakdown, I could provide also the original request that was sent to OPM if you wish.
Please, that would be very, very helpful. Thank you very much. Thank you, Madam Chair.
Thank you very much, Dr. Gill. I believe we have all the information. I have nobody else that has, except for, I'm sorry, Representative Nolan has a question. Just ask him to talk loudly.
Good afternoon, sir, and everyone that is present. I'm just hoping that we can get a report from you that shows the amount of deaths that you have responded to with reason, sex, and race, just to get an understanding of what we're having issues with.
Yeah, we can easily put together a spreadsheet with listing all the causes of death, the age, the gender, ethnicity, everything. That's very easy for us to do.
Thank you, Madam Chair. Have a nice day. Thank you for coming before us.
No. Thank you very much, Dr. Gill. Have a nice day. We really appreciate your work and we'll probably see you in the working group. Thanks.
Thank you.
Thank you.
Next, we have the Office of Health Strategy.
I was gonna say, don't sit down.
I know.
Come on up. It's Friday. I'm going to sleep.
You know, by the time you get home, you're gonna be all wound up. Commissioner, no, I know, I can't call you Commissioner. Executive Director, the floor is yours. Go ahead.
Thank you very much. Is it microphone on? Is the red light on? This one is. Okay, I'm using.
That's all you need is one on. Just gotta pull it closer to you.
Okay. How's that?
That's good.
Great. Good afternoon. Representative Nolan, Representative Walker, Senator Austin, other members of the Appropriations Committee. I'm Deidre Gifford, Executive Director of the Office of Health Strategy. The confusion around my title is, you're not the only one, Senator, so don't. Executive Director, yes. Of the Office of Health Strategy, here to obviously testify in support of the governor's biennial budget for 24-25. I'm joined by members of the team, Chief of Staff Kim Martone, and other members of the OHS staff, who I've been fortunate
enough to inherit from my predecessor, Vicky Veltrian, who's been helping with preparations for today. In the past, Madam Chair, we have done a brief testimony, so I'll do a very high flyover and then, okay. So as you probably know, OHS consists of 3 teams that work collaboratively to meet our mission. There's the Health Systems Planning Unit. It's responsible for the Certificate of Need, regulatory process, and health system reporting. There's our Health Innovation Team that utilizes our data to develop and implement healthcare policy reforms. And then there's our Health Information Technology Team that includes a data team and oversight of the Health Information Exchange. We currently have 44 authorized positions at OHS, 39 of which are filled. We've been fortunate enough to fill 4 positions just in the last month, and we have another that we're very close to filling. And as you have seen, the governor's proposing an additional 11 positions for the agency, which would bring our total authorized count to 53. Just to highlight a couple of our major accomplishments in the past year, as you hopefully are aware, and we'll be talking about more in the coming month, we implemented our new healthcare benchmark initiative, including collection and validation of data for our first year of reporting, which will happen later on in March. We implemented a new hospital reporting requirement for community health benefit, which has been of great interest and we're very much looking forward to. We have hired a contractor per last year's session to conduct a study of behavioral health payment disparities and coverage disparities. We have convened and reported to the legislature on a physician practice work group to study the oversight and regulation of mergers and acquisitions for physician groups. As you are very well aware, we worked collaboratively with the Department of Social Services to develop and launch the Covered Connecticut program. And we have recently contracted with 10 community-based organizations who are going to be helping us with outreach, both on Covered Connecticut and on the Medicaid unwinding. So you've seen the budget, which totals $18.7 million for 2024. Couple of highlights. You'll have noted the transfer of funds to support Covered Connecticut from OHS to DSS, which we fully support. Funding 5 new positions to support the governor's proposal on capping out of network costs for hospitals. Funding 3 new positions to carry out the recommendations of our state health IT plan. 2 new positions to enhance our very broad data mandate at the Office of Health Strategy. We collect a lot of very significant health systems data and have needed additional analytic capacity and expertise. So we're very grateful for these new positions. A new position to support enforcement of the Certificate of Need program. I've in my short tenure here, gotten a lot of questions about our ability to monitor and oversee Certificate of Need applications that have been approved, particularly those that come with conditions. So we're proposing a new individual there. And then $600,000 in ARPA funding to support a consultant to analyze pharmacy benefit managers, which are a significant part of the issue around drug costs in Connecticut. So thank you for the opportunity to deliver this testimony, and we're happy to entertain any questions that you have on our budget.
Thank you very much. We have a bill that will be in front of us that talks about the assessment onto insurance companies, and the property and liability insurance companies are saying that because a good portion of your budget comes from an assessment onto the insurance companies. And they're saying, why should we pay for the Office of Health Strategies or any of the other offices that are being funded relative to healthcare? I don't need an answer today, but I would expect when that bill comes out that you'll provide testimony for us on that, because if we take that group out, what does that do relative to the funds that you would have available? And I'd also like to understand, if we're supporting all of these organizations or agencies or departments by assessments on insurance companies, does that not increase the cost of the insurances? Don't they pass that along to the regular consumer? I don't know if you want to comment on any of that right now.
With respect to your first question, Senator, we will be happy to go back and break down both for our agency and what percentage of the overall assessment. We'll work with our colleagues at OPM to provide you responses. On the second question, I did actually ask the health insurance industry to quantify for us at OHS what % of their overall revenue this assessment represents. I think that's a really key question. I have not yet gotten a response to that question, but we will follow up with them because I think to respond to your question about the impact on ratepayers, it's important to know how this assessment, what's the size of it relative to their overall revenue.
So one of the questions that I always get from constituents is that their deductibles are often so high, it's almost as if they have nothing for insurance, only a catastrophic event that would be covered. In particular, municipal school departments have at least 3 or 4 in my district alone have a $7,000 deductible, between a $4,000 and a $7,000 deductible, which is essentially no insurance for anybody. Because if you're just going for a regular doctor's visit you might have a cold that's lasted forever, you'd never get to that $7,000 deductible.
Yeah.
So are you planning on coming up with a way to reflect what we could do on strategies to address this particular issue? Because I find that those people are not really they essentially have no insurance unless they end up in the hospital with some catastrophic need for care.
Senator, it's a really important point that you're making. We, in our materials around the governor's bills, have been talking about a survey that was done in Connecticut last year that spoke to this very question. Over 50% of people in Connecticut said that within the last year, they had cost-related concerns about their ability to get health care. There was a recent Gallup poll that showed that 44% of people in America had avoided care within the last year because of costs. So this is precisely why the governor has proposed both House Bill 6669 and Senate Bill, thank you, I blanked, 983, both of which contain a significant number of proposals. There's 10 altogether that would start to tackle this issue of healthcare costs. I will say, apropos to your question about the insurance assessment and its contribution, we know that by far and away, from looking at our data that I referenced and our benchmark work, that I have to always acknowledge Vicki for starting and really getting going, that the primary driver in Connecticut and around the country of increasing costs is hospital outpatient services, hospital inpatient services, and drugs. Those are the 3 main drivers of the increases in healthcare costs that we're seeing. And we need to tackle those things from multiple different angles. And that's, we'd be happy to talk further about the governor's 2 bills, but that's the overall thrust behind those 2 proposals.
So I don't want to talk about the governor's 2 bills right now, but I know too many. Personally, I don't like going to the doctor, so I just don't go. And that's a different argument altogether. But there are people that have to go to the doctor for a variety of things that I force myself to go once a year, and then they give me a sheet that says I'm supposed to go for tests, and I ignore it. but whatever. So.
You don't need to say this online.
I don't care.
We're trying to get people to go to the.
No, you are trying to get people to go to the doctor. I'm trying to provide a resource for them to be able to go if they so choose. And that's what I find good. And that is why I'm hoping that you come up with a strategy, because I don't like the high deductible plans, which essentially don't provide any resource for people that have real needs to go to the doctor. So one of my constituents had a daughter who had type 1 diabetes, and she was looking for a diabetic pump and could not get it because it was not going to be below that $7,000. They had to pay the $7,000 first. And they didn't have the 7,000, nor did they have the 4,000 to get the pump. So that means to me that we're not really addressing the issue relative to that. And are you including in your analysis relative insurance, my last question, and I'll be turning it over to Representative Walker, the partnership plan that is available for people? Are you looking at the partnership plan and how successful it is that the state has?
That is at the moment not really in the purview of OHS. So we haven't been doing analyses specific to that plan.
So I think that that's something that we would be interested to, if we're going to analyze insurance companies, we should be analyzing the insurance that we have ourselves. And I think that that's something that we should look at, but thank you very much. I'm just going to go with Commissioner. Representative Walker.
Thank you. And good afternoon, Madam.
It's hard.
I'm used to saying Commissioner. Welcome in your new position and everything. I have to say, you seem like the burden has been lifted.
A new burden.
A new burden, but it's not the same kind. But no, I'm very happy you got this position.
Thank you.
So tell me, the 5-year statewide health IT plan, explain that to me, please.
Yeah. So I'm gonna, at this point, because I'm still getting up to speed on that plan, I'm gonna ask our HIT lead, Sumit Sajnani, to give you a brief summary, Representative.
Thank you. Good afternoon. Yep, there you go.
My name is Sumit Sajnani. I serve as the Health Information Technology Officer based out of the Office of Health Strategy. We, for the first time last year, published a robust 5-year health IT plan, and it's a statewide health IT plan, meaning it's not just for state agencies, it's truly for the state. And the way we developed the 5-year health IT plan is through major stakeholder engagement, and that included patients, obviously, advocates, providers, payers, and several others, to really understand what the key challenges in the state are and how we can put together some solutions around health information. And some of these key highlights within the health IT plan is to look at clients that are being serviced through multiple different entities, whether they be state agencies or external community-based organization. How do we share with appropriate privacy and consent their information so we can provide better referrals, so we can truly understand the whole scope of their need and look at opportunities for getting them the care in a timely fashion for better health outcomes. It has components in it to increase more of the data standards. So multiple agencies are collecting different information, and sometimes you can't leverage that information from an analytics or policy perspective because different information is being collected. An example of that would be race, ethnicity, and language. One of the things that got implemented last year was the need across the state, and this applies both to state agencies and providers at large, is to start collecting race, ethnicity, and language in a standardized fashion. So we've known about the challenges around this. This is not new information that's being collected, but in the new standard that's been published by OHS. So these are some of the key examples of the kinds of things that the 5-year health IT plan tries to accomplish.
So what you're doing, you're gathering information from health entities that we have in the state government right now. So you're doing MOUs with all of them to acquire their data?
So in terms of the race, ethnicity, and language, they collect the data themselves.
Okay.
At an aggregate level, they might be providing reports. They're not providing individual data to the Office of Health
So they can be
Strategy.
clustered,
But
okay.
once they collect the race, ethnicity, and language data, and that's just one example of data standardization, they're able to analyze it for a variety of reasons, and not just for analysis purposes, but even for patient care purposes. So if you know if somebody has a language barrier, you can address that appropriately with translation services and other kinds of things.
So this is sort of your own IT system that's going to evaluate already gathered information that other agencies have already gathered.
It's a two-part thing. So we're looking at agencies and providers to utilize internally within their entities the standardized data collected, and in terms of data sharing at an aggregate level for certain federal and state reporting to report that in the new standard.
So in that grouping, you have 3 personnel that are added, and then you have fund staff positions to enhance agency data analytic capacity, which I'm assuming is going to be part of that. So there's another 2 people, so that's 5. And then you have another position that monitors certificate of need, oh no, separate, sorry, no. So these 2, so you're adding 5 into this 5-year statewide health IT plan, is that correct?
So if I could add, Representative, the 2 analytic staff that are listed are separate from the 3 working on the state health IT plan that submit.
They're not working in tandem together?
Well, the Office of Health Strategy collects a lot of data as required by statute. We collect data on hospital performance, on financial information from hospitals. We have our all-payer claims database. We have a community benefits report. I learn every day about a new data set. We have hospital discharge data, emergency department data. All of that comes into the Office of Health Strategy, and it's meant to be used. It's in statute because it's meant to be used for health planning and health policy purposes. OHS has not had sufficient analytics staff to analyze the data that we already receive. So that's what those 2 positions are meant for. What Sumit was referring to is this new state health IT plan, which is really external to OHS. As Sumit mentioned, it's really by statute, an IT plan for the entire state. And OHS is charged with both developing that plan and then using whatever levers we have to help it get implemented. One of those levers is standardizing race, ethnicity, and language definitions, but it's separate from the kind of statutorily mandated data collection that we do as an agency. So they're really 2 different bodies of work.
So as you start to branch out into analyzing more of the data that has been available and collected, is there going to be more branching out? Is this just the beginning of how you want to expand the agency?
Well, many of the entities that submit data to us, hospitals, for example, invest resources in submitting data to us that's accurate, complete, and as they are required to do. And I think it's our responsibility to make sure that we're using the data that we collect. So to answer your question, Representative, I think what we're focused on now is actually making sure that the statutorily mandated data is being appropriately utilized and reported on to you all and other policymakers. And we have plenty to do with the existing data sets before thinking about expanding to other data.
No, I was interested in the Office of Healthcare Strategy before, but it seems to have blossomed a lot in their scope. So that's why I'm trying to understand. And you're also evaluating oh, you're creating accountability and oversight over pharmacy benefits too?
Well, one of the mandates of OHS is to think about a coordinated healthcare strategy for the state. That includes access, quality, and cost. And those are obviously a very large mandate. And one of the, as I mentioned earlier, one of the things we know to be driving healthcare costs is drug costs.
Right.
When we start to peel back the onion, the layers of the onion, and say, how can we start to tackle this? Pharmacy benefit managers keep coming up over and over again as an area that A, we don't have a lot of information on, and B, needs further exploration and transparency. So it's an appropriate place for OHS to study what might be future transparency or other initiatives around PBMs. It doesn't mean that it would translate into further responsibility for the agency, but as a place to actually do the study, I think it makes sense.
Okay. Okay, I'm sure I have some more questions as I try to understand this, so I will, I'll keep asking. Representative Dillon, then after Representative Dillon, Representative Nolan. Representative Dillon.
Thank you, Ms. Gifford. Whatever you.
That works too.
Yeah, I wonder, I'm confused. You know, I've watched the morphing of this agency over a long time, and it seemed to me, and I don't know this, and it's fine if I don't, that some of the data is already in our Chimes database. And I guess that prompts me, I guess maybe that isn't true, but some discharge data is in our Chimes database. And I'm wondering how you cooperate with the health department and what data is new that isn't being collected.
So as you know, and I don't know if Pam or anybody else wants to back me up here since I'm newer to the agency, but as you know, OHS is a new agency just since 2018. And many of the functions of OHS were in the Department of Public Health, and the agency still sits within DPH for administrative purposes. But the legislature created this office, I think, because they saw a need for a place where health policy across public and private payers would be focused. And so OHS does have a fairly broad mandate. I know we work very closely to not duplicate hospital data collection from what's already duplicated through the Chime data set. I don't know if, Tim, if you have anything else you want to add there about how we work with CHA or Sumit.
So the three data sets that we're collecting essentially is discharge data from inpatient surgery, outpatient surgery, and emergency room department discharges. This data is being used for a variety of purposes at an aggregate level, and I think that's an important concept for trend analysis, looking at how many people, for example, at what times are going to emergency rooms, how that trend over the years has been. We've published a variety of these kinds of reports that are helping educate the state and various stakeholders on how that trend analysis is going. That is a slightly different purpose than how DPH or other agencies might be collecting some related but separate data. The other data that we're collecting is the all-payer claims database, which is essentially the commercial, Medicare, and Medicaid, but not 100% of commercial, but commercial minus ERISA plans that are processing claims. We're collecting that data again from a state policy perspective. That was previous to being with OHS, was with the Health Exchange, but back in 2018 was moved from the Health Exchange and then administered by the Office of Health Strategy.
I wonder if you all could provide this information to the work group so that I'm looking at the number of people who are participating here, and I know that there could be very high interest, but there are competing responsibilities today. And that would be really helpful. But I still have questions about the Chimes database, but I won't chase that more right now. My second question, I guess, is
Representative Dillon, can you just clarify which data you're referring to?
pardon me?
Can I just clarify which data you're referring to that you'd like more information on for the work group?
That which you collect, and what the overlap would be with the Chimes database.
Okay, the data sets we collect and the overlap with Chime. Got it.
Great. I think that would be accurate. My brain's getting a little fuzzy. It's been a long day, but I think that was where I was going with that. Thank you. And the second question was about race. I'm not going to ask you to define race. We don't, but since there was a mention of that in how we would be looking at certain kinds of patterns, I wonder, and again, this brings back the health department, not because they've raised the issue themselves. At the beginning of the pandemic, I know some of us were very intently watching where the cases were, and we were looking for a breakdown of race, and we were looking at availability of vaccinations by race. And many charts that I got over time, the biggest chart, which was mammoth, would say, don't know. And for that reason, I guess I want to poke a little bit at some of the data you're going to be collecting. Who's monitoring the data collectors? And how clear are they going to be about what their mission is?
So, Representative, you're obviously identifying a really critical issue for everybody in healthcare and in public health. I just want to be clear about what OHS's role is and is not here. What Sumit was describing around race, ethnicity, and language was really about developing standards for the state. And so to your point about the definition of race and the often missing data on race, our work is around standardizing those definitions and then sharing those standardized definitions so that individual agencies and entities who are themselves responsible for collecting the data can do it in a standardized and uniform manner so that those data can be combined when it's necessary and appropriate.
Okay, well, and then I won't, the one that stood out the most in terms of non-response was race, at least when we were looking in the first year of the pandemic, but it would hold true for any data collection you're engaged in, right? Where we would want to know who's doing the collecting and whether they know, whether they agree on what they're collecting. Thank you.
Thank you. Representative Nolan.
Thank you, Madam Chair, and good afternoon. And kind of on a little bit of what Representative Dillon talked about, real early in your statement, you talked about disparity. And I'm just wondering, what does your office do in regards to anything that has to do with disparity? And then if there is something to do with it, does your office give recommendations after you find that there are whatever it is that you find? Could you elaborate on that?
Yeah. So I think the key thing there is that you can, this is the I think point Representative Dillon was making, you can't identify disparities if you're not appropriately measuring race and ethnicity. So the work that OHS has been charged with, and I can't remember if it was last session or the one before, maybe the one before that, when we were given the mandate to do the work around race, ethnicity, and language, is really to help the standardize and improve the reporting. That would then allow us to study disparities in health outcomes. So our overall mission and mandate at OHS includes access, quality, and cost, and equity is a key part of all three of those things, Representative. So I would say that the questions about equity sort of flow throughout all of our work. And we really make an effort to think about questions of equity whenever we're talking about a policy issue. Getting back to the issue that Senator Austin and I were discussing, for example, about affordability, we know that households of color and households that include an individual with disability are disproportionately impacted by questions of affordability. The example the senator gave around diabetes is a good example. Obviously, people with more chronic healthcare needs are going to be more impacted by affordability issues. So that's one example of the equity lens that we try to use in our policy work.
And to follow up on that, and with the lens that you're looking at stuff, what kind of disparities are you finding that need attention?
That is a very large question with a lot of answers.
Okay.
So I think well, I can point to one specific area where we have been collaborating with DSS, the Office of Early Childhood, and DPH, which is around maternal health and infant outcomes. We know that we have disparities in birth outcomes in Connecticut and around the country. So we're working hard on and have proposed some solutions to address that for this year's session. We know chronic disease differentially impacts communities of color versus other communities. And as I said, issues of affordability. So those are a couple of examples, and we'd be happy, Representative Nolan, to sit down and talk further about, and maybe in collaboration with our partners at DSS and DPH about efforts that we're making there.
Okay, and those, you said DSS, Office of
Early Childhood.
Early Childhood, and DPH, and that was in regards to maternal health?
Yes, and those are some of our partners in the home visiting program that we're piloting starting in Bridgeport this year, and some of our work on maternal health as well.
And it sounded like you might have a plethora of stuff that might have to do with disparities. Is there a list that you can provide us so that we can understand and see? And the reason I ask this is because in order for us as legislators to conquer the disparity issues, it would be very good for us to get the reports that you might have that shows that plethora of stuff, so that we know how to attack it and put whatever we need to in priority based off of what you're finding. As we've seen through the pandemic, there were just so many different areas in which people weren't getting care like other people. And this is a way for us to get on top of it and to start, if not before this session gets over, to be prepared to have what's needed for next session to ensure that by funding or by just various things that I can't think of right now, how we can attack the disparities that are going on in Connecticut. Unfortunately, we know there's a lot of them, but I'm glad to hear that your office has numerous ones that you might be able to share that we might even not know because we don't have the data. So to now understand that there may be data in your office along with, we know, other offices, it will be great for us to get. And I'm sorry.
Yeah, I just wanted to add a little bit. Kelly Cinco, Director of Healthcare Innovation at the Office of Health Strategy. So I think you might be familiar with our healthcare cost growth benchmark initiative. So cost growth is one part of it, but the healthcare benchmark initiative also has a quality component and a primary care spend target component. And something that's really important about the quality benchmarks, which aren't going to go into effect until next year, is that we're really going to try to stratify those by race assessing language. So we're working with that and working with Sumit's team and Connie with the Health Information Exchange about how we can get different kind of quality data out of there and really stratify it so we can get at the equity issue and actually collect the data. And also with our primary care spend target, that's going to give us a little bit more information about how many people are accessing primary care, what's getting spent on primary care, because social determinants of health, as you might know, a lot of people are trying to focus primary care on prevention and doing things like transportation to appointments or food insecurity or different things like that. So those are just some of the things that the Office of Health Strategy scope is looking at right now. And then with Dr. Gifford's leadership too, we're going to be looking at, where we can move in those directions and what kind of data we can collect. So I just wanted to make sure you were aware that we are doing a lot of things with disparity equity, and we'll definitely get you that list you asked for, Representative Nolan.
Can I just, did I hear you say that we don't have a statutory definition of race? Did I hear that?
We don't, I think I said standardized,
Standardized?
but I don't want to.
Okay.
I don't know the answer to that question, Representative Walker. I'm assuming the answer is no, and that's why OHS was given the mandate of trying to standardize across the way agencies collect, but we don't, apparently did not previously have standardized definitions. And so particularly around the way that race is collected and categorized when we're asking people that we interact with about race and ethnicity.
That is interesting, because I've noticed that we have someone had gotten a ticket for, I forgot, running a light or something. And when they did, they looked down and they were defined as Latino, even though they were Black. And it was because of her last name. And it was more interesting because they assumed a Latino is not Black, it is white, which is also very interesting. So that just says to me that we avoid this. And so we come up with different categories just to sort of move it away, but it skews the statistics in trying to understand who are the population that make up the state of Connecticut. And we sort of move back and forth in that. So I worry about that a lot. Okay, all right. Thank you.
And that actually was a second question. But before I go there, you talked about
We're behind.
okay. You talked about a list that wouldn't be ready until 2024. Is that what you were saying?
Oh, so the quality benchmarks go into place for 2022, but the data lags a little bit. So the quality benchmarks will go into effect next year.
Okay.
Yeah.
But there is a list of stuff that you have now.
Oh, there is a list of stuff. Yeah, I'm talking about one very specific initiative.
Okay.
That we will definitely get you that list.
If we can get that list now versus.
Oh,
when you
of
get that
course.
together.
Yes. And it'll have that description of what that is in the list.
We would like that.
Yeah.
We would like that.
Definitely.
Thank you. Pat, do you have another question or a statement or something? But we're behind time, so if it's.
Yes, Madam Chair. I would just like to ask you to bring to the work group a breakout of how the new positions will be used and whether any of them will be used for the CON review.
Will do.
Yes.
Okay.
I think if I recall, it's 10 or 11 new positions.
Yes.
And so if you could, given the time that we're dealing with, if you could provide that just to the work group and we can discuss it there, that would be really helpful.
And can I just clarify something for Representative Dillon for 1 minute?
Uh-huh.
She was talking about the CHIME database.
Yeah.
And the CHIME database is with the Connecticut Hospital Association. So our data isn't duplicative. They're actually the intermediary that provides us the data that we get in our hospital discharge database. So I just wanted to clarify that for a minute.
Okay, thank you.
You're welcome.
Thank you.
Thank you, everybody. Thank you very much. Thank you for your testimony. Thank you. Have a good afternoon. Next, we have the Department of Mental Health and Addiction Services. Huh? Excuse. I know. Oh, my husband was watching. He said, "You talk about your daughter, you know that." Good afternoon. How
Good
are you,
afternoon.
Commissioner?
I'm well. How are you?
You're the last person we're going to talk to tonight. This is so good.
Glad to
We're,
make you
we're so
happy.
punchy, it's really bad. So please bear with us. It's really real. But go right ahead so that we can get into the questions. Go ahead.
Okay, and I'd like to introduce Colleen Harrington. She's my deputy commissioner as well. Sure. So good afternoon, Senator Austin, Representative Walker, and distinguished members of the Appropriations Committee. I'm Nancy Navarrete. I am the Commissioner of the Department of Mental Health and Addiction Services. I appreciate the opportunity to testify in strong support of the Governor's Bill 6659, an act concerning the state budget for the biennium ending June 30th, 2025, and making appropriations therefore. So as you probably know, we're a large healthcare agency. We serve adults over the age of 18 who are living with mental health and substance use serious conditions. We generally serve individuals that are underserved or underinsured. So they would not, if not for our services, have access to behavioral health services. Last year, we served over 95,000 people, and that is slightly down from the prior year, but we usually serve around 100,000 folks a year. We're also responsible for prevention across the lifespan, so children and adults in the behavioral health space. We're really a public-private partnership. So we have state-operated facilities and programs as well as private nonprofit organizations that we contract with, anywhere between 140 and 190 agencies year to year that we partner with to provide mental health and addiction services. We operate 13 local mental health authorities. 6 of those are run by the state. 7 of those are run by private nonprofit providers. We operate 2 very large hospitals on our Middletown campus, Connecticut Valley Hospital and Whiting Forensic Hospital. The governor's proposed budget contains a number of critical new investments that will allow DEMIS to better execute our mission of promoting wellness, preventing illness, and strengthening a recovery-oriented system of care for people with serious psychiatric and substance use conditions, as well as supporting expansion of vital behavioral health services to individuals who rely on our system of care. The department appreciates the governor's support and looks forward to working with legislators as the session continues. The next part of my testimony, I'll go through the various modifications and adjustments to the budget, the fiscal year budget 2023.
Excuse me, do you want to go through them or do you want us to go just into questions and probably?
If that's your preference.
Yeah, I think it's
Representative?
probably, yeah, because I think, and then if we don't cover all of them, we get that information from your
Okay.
testimony. Because I'm trying to keep us close to the time that we're supposed to be, so. And I noticed everybody came in when you did. So, no pressure. I'm sorry, so the first beginning questions, and I did not hear your beginning opening statements. How many people do you have authorized positions? How many authorized positions do you have in the budget right now?
So right now we have 3,420.
How many filled?
2,825. Leaving 595 vacancies.
And 595 vacancies. How many do you have any in the queue or?
Those would be the positions that are in the queue.
The 595 are in the queue?
Yes, and
Some of the
Really?
reports might show a higher number than that,
Mm-hmm.
and that's because we're aggressively recruiting. So for example, if I'm recruiting for a master's level clinician, I will not only recruit for a social worker, I'll recruit for a counselor and a marriage and family therapist, because I want that position to go out all different ways to be able to bring one person. So that one position may actually be reflected 3 times.
Wow, okay, all right. How many patients do you still have at Whiting?
We are almost at capacity. The report this morning showed 6 openings.
6 openings?
Mhm,
So
6 beds
how
open.
many patients?
So we have 91 at maximum. Our capacity is 91 and 138
138 at
Dutcher.
at Valley?
at Dutcher. At Dutcher, I'm sorry. Dutcher, which is the step down facility.
Oh, okay. And I mean, 138, you said?
Mhm.
Okay. I'm sorry. You gotta speak up a little bit,
Yes, I'm
louder.
sorry.
Whiting has 91 and 138
Correct.
in two different sections. And then Connecticut Valley has,
They're usually pretty full. There are over 600 clients there.
wow, 600. Okay. So you, last budget cycle, there were quite a few items in your budget that were ARPA funded.
Mhm.
In those, were you able to fill any of those, utilize any of those dollars from ARPA funding?
Yes, we were. So in terms of programs, we were funded for mobile crisis for our private nonprofit providers to bring them up to 24/7 ability to deploy folks into the field 24/7.
Okay, that was ARPA funded.
Yes, it was.
Okay. And is that going to be annualized back into your budget or?
Yes.
Okay, so this started at ARPA and was maintained. Okay, and the additional hospital discharges, was that?
Yes, and that is annualized, and we received additional caseload growth in this budget.
And you, and there's another 2 million here, okay. Housing support,
Yes, and that is also continued.
okay, that was. Okay, Hispanic behavioral health,
I'm sorry.
Hispanic behavioral health,
We have about $5.3 million invested in
Okay.
those services.
okay, million, okay. Let's see. And you transferred 43 people into. for-
44 for IT, centralization of IT. So
I'll just breathe. That must have been a hard transition for you.
actually, it's working pretty well. I don't have any complaints about it. It's been, you really can't notice the difference. We still have access. So across the street, I still have access to an IT person on site any day that I'm there. There is someone right there if there should be a problem. The same folks that we're used to dealing with have remained with the organization right now as they're in the process of cross-training people and being able to deploy people more broadly. But it really has not affected our day-to-day. It's gone rather smoothly.
Okay. I'm going, so I know you and I have talked about this before. We've talked about utilization of mobile vans in distribution of methadone and things like that. And so I asked the Department of Public Health for the rules that have been established, and I've yet to get those rules. I'm not going to say that it was directed to me to ask you where they are but it was said that they had completed their process and it's now passed on to the next agency. Are you the next agency?
No, it's gone up to administration. So the work group completed their work. That included DCP, DMIS, DPH.
And now those have been completed and passed on, so they're being reviewed at administration.
And who's the administration?
OPM?
OPM, okay, all right. And so it's under administration. Okay. My concern is that when we look at where they are going to be utilized, we must be careful to not have them being distributed in front of schools or nursing homes or any other location where we have already identified you cannot distribute drugs of any sort in those facilities. Would you pass that on? I'm not going to ask you if that's in there. I'm just going to say, would you please pass that on? Because we are really going to have a real problem if those things are not taken into account. And the other part is making sure that our communities have a voice in these facilities that are being established. There are some that are good stewards and they've done a fabulous job and they work with their communities, and then there's some that don't. And we still have in New Haven, we still have one that we still are struggling with. So how do I tell my constituents in New Haven where they can send their voices to express their concerns about the utilization of this program?
I will pass that on. Absolutely. Yes.
Okay. Okay, Senator Austin, do you have any?
I will in a minute.
Okay. Representative Nolan, do you have any? Okay, go ahead.
Good afternoon. Very interested in just knowing a little bit more about your young adult services and your cannabis prevention. You don't have to answer it now because I know we're short on time. But those two areas I would hope to get some information in regards to. But today, if you could let me know a little bit about your social equity and innovation fund.
So there was a position, is that what you mean? There's a position?
The
That-
social equity? Or are you
As
talking
part
about-
of the advisory committee? Or you're talking about where the dollars are coming from for the cannabis?
Yes.
Okay, so we're getting over $2 million in the first year and 3 in the second year to be able to implement prevention, monitor, almost like we do with the tobacco products. So we'll go do secret shopper type activities with merchants to ensure that folks are not selling to who they shouldn't be selling the product to. A very large media campaign, and then also working with local prevention councils to infuse prevention strategies in local communities.
Now, is your media campaign, explain that. Is it?
So it hasn't started yet, but we do have a vendor. What we did, because we wanted to get messages out very quickly, we did a very small compact campaign to get the message out about what the laws are, what you should know about. There's a campaign, if you go to the website, beintheknowconnecticut.org, that has a lot of our information there. And then we've just secured a vendor, and that vendor will be working with us to do a much larger campaign.
Will you be doing any campaigning in regards to telling youth the dangers and why we shouldn't smoke cannabis?
Yes, so it will be focused, some of the special populations that we'll focus on are pregnant women, young children, safe storage. Those are the kinds of messages that we'll be getting out there.
Okay. And I know you'll be putting it out there, but how do legislators find out what you're putting out or when you're putting it out so that we can know what's going out?
Happy to circle back to you when all of that is launched. In the meantime, if you'd like to go to beintheknowconnecticut.org, that'll give you a good overview of some of the areas we'll be focusing on.
Thank you, ma'am.
You're
Thank you,
very
Madam
welcome.
Chair.
Thank you, Senator Austin.
Thank you very much, Madam Chair. So Commissioner, your agency not only handles addiction relative to drugs, it also handles addiction relative to gambling.
Correct.
And you have a report due to us. Do you know when that report will be available for us?
I believe it's submitted
To
for review,
Oh,
And
to the administration
yeah,
for review?
yeah.
Okay, so we can ask them where it is. And how much money do you receive and what kind of programs do you have available for gambling?
So we have prevention programs. We have a hotline. We work with our RBHAOs to get messages out locally. So they work with their prevention councils and their local constituents to be able to give alternative strategies, engage youth and young people in media messages, for example. We are also doing some research. So we've just contracted with a researcher that specializes in LGBTQ population. And so we'll look at, well, is gambling affecting them differently? Are there specific issues that we need to be aware of? We're doing another study on college campuses. And we'll take that information and then translate that back into our media campaigns.
Have you seen an increase in the usage of programs, not the phone calls, but the usage of programs since we passed sports betting and online gaming?
I think it's a little too early to tell, but you're absolutely right. We have gotten double the amount of phone calls through the hotline.
My understanding is the phone calls have been relative to my account online is not working and I can't get anyone from customer service to respond. So I don't, that's why I want to get away from the phone calls because I don't think that shows a true picture. If you were seeing a double amount of the need in programming, that's a different story. And my understanding is that's not what has shown up thus far.
Correct.
Thank you. Thank you, Madam Chair.
Thank you. Representative Dillon, followed by Representative Nolan, followed by Representative Exum. Oh, and followed by Representative Dathan. Go right ahead. Representative Dillon.
Good afternoon, Commission. Thank you very much, Madam Chair. For the work group, I wonder if you could provide a narrative for adjusting the funding on the substance abuse demonstration. And I wonder if you could provide an update on the support program for military families and how many you've served and so forth and the scope of services. We don't need to discuss that today, but I wonder if you could bring that to the work group.
Will do.
And those are two things. And then the third is there were, did I leave one out? There were a lot of questions from our members about the suicide hotline and whether the dollars there, who they will cover and how many, whether they were left. That would be helpful as well.
Can you repeat that last part of that question?
An explanation of the funding for the suicide hotline, the durability of it.
Thank you. Representative Exum.
Good afternoon. Good to see you, Commissioner.
Good afternoon.
I just have a couple of questions. One, just a clarifying question with DEMAS, just for my education. Is it mental health and substance, or is it or?
Both of those.
It's both. It's
Yes.
typically both, a combination. Okay. I have a question or two around, I heard Representative Dillon just mention the suicide hotline. And I'm happy to see the funding in that. That's something we really worked on last year, making sure that we were supportive of that funding. As far as the process itself, so I've had an issue that came to me from a constituent. And it happened that they called 988, had a fantastic experience, but then there was a drop between what happened when they transferred. They were told that 24/7 hours were not available. No one came out and there was no follow-up whatsoever. So that made me afraid for the way this process could work. So I'd really like to know how that data has been tracked when someone has made that connection, as far as the services that need to, that follow-up that needs to take place, how that's captured so we can make sure that doesn't happen.
Sure,
Okay.
it's hard to speak to an individual
Right,
case.
right.
And our mobile crisis is in the process of becoming 24/7. So not everyone in the moment, not every mobile crisis unit in the state is 24/7 right now. That's been affected by the workforce shortage also, especially on second and
Yeah.
third shift.
Right.
But when examples like that come up, we encourage people to contact the department directly so that we can problem solve. And certainly we don't want anyone to fall through the cracks. In fact, one of the programs that you all implemented last year was a program where when individuals connect with mobile crisis, and let's say there's a waiting list for outpatient, we have a mechanism now to be able to connect and engage with people through a clinician or case manager so that they do not do that. And they can start that relationship and become engaged in treatment.
Okay, and so what would happen if the 988 call goes is for someone younger? That's in a different, when you handle people who are over 18, is that correct?
Correct.
So no matter,
We work very closely with DCF and we use the same vendor.
okay,
So it is pretty seamless.
okay,
And our teams work very closely together, and our models are very similar and use both 988, 211, United Way. So it's a very tight system.
okay, and I'll follow up about this particular thing, just because I know this isn't necessarily the forum, but
Sure.
I'm very interested in just, I knew it was new, but how that really works together, I know is really important once they make that connection. But the 988 piece I was told went really, really well. How does it work as far as wait lists for individuals who are in, say, a particular setting and they wish to get a bed in a different place that's less restrictive? How does that process work? And if this isn't the place for that today, because I don't want to take up the time, I am really interested in learning about that. If they're in a particular facility and they wish to have a less restrictive, but they're on a wait list for a bed, like how that piece works.
Every level of care is different, but I will say that everything is front facing. So if you're interested, that we have a front facing website that shows substance use beds and mental health beds and where they are and numbers to connect. Now, of course, it's a point in time. So, a bed may be open this minute and not the next. So we encourage people to connect via the information that's on the website. But we try to be as transparent as possible in terms of what's available across the
Oh,
state.
that's good to know though, that it's on the website. And then the last question I have is about the opioid epidemic that is underway. And how does the DEMAS budget really address that?
So we address the opioid epidemic in two ways, one through federal funding and one through our core services. So the very core of our service is a continuum of substance use services. Someone else mentioned this SUD waiver. That's a collaborative that has had a lot of input with DSS, with DCF, CSSD, DOC. It's really been an interagency project with all levels of care available to folks. There were some levels of care that Connecticut didn't have that we've added. It's been an infusion of $70 million back into the system because of the federal match. So there are more services available, and getting into a bed is all determined by medical necessity. Staffing patterns have been bolstered as a result of this project, but you counter that with the problems that we have with the healthcare shortage, and so providers are struggling with that.
I understand that. That is a consistent theme for
Yes.
sure. Thank you. Thank you so much.
You're welcome.
Thank you, Madam Chair.
Thank you. Before we move on to Representative Nolan, can I ask how much money do you receive in federal dollars for your programs? And do you have employees that are paid through federal grants? How many do you have?
So last fiscal year, we're very good at bringing in federal dollars. We brought in probably around $160 million in federal funding, but that does include, it's a bit inflated, it includes some COVID dollars, ARPA dollars as well. But we're very good at securing discretionary grants, which sometimes are targeted around special populations like pregnant and parenting women or the YAS population, for example. or specifically targeting OUD, opioid use disorder.
And how many employees in your staff
yes.
are on federal dollars?
Not many. We have our student workers, so maybe 30 altogether, that those positions remain open during the year. But we hire those young people to do the work with us in our tobacco program, the Secret Shopper program.
Oh,
And then there may be 2 other employees through the state opioid response grant.
Okay, great. Representative Nolan.
Oh, thank you, Madam Chair. I know you understand that we have New London navigators in the city of New London. And I'm just wondering, is there starting to be any consideration to use that statewide? I know we just passed it in some legislation, but it is working so great. And they're doing such a good job. And I would just hope to see that there is talk about it moving outside of New London
Thank you
and
so
other
much.
areas. It's not just New London, but southeastern Connecticut, and spreading throughout the state of Connecticut.
Thank you for that question. The answer is yes, and folks should be watching our RFP pages.
Okay, and just so that we have a little bit of information on it, can you send us what you're putting out in RFP so that we can
Once it's released,
Yes.
sure, yes.
okay. And the other thing is there's a program called Between Us. Do you know of?
Not familiar.
No, no. All right. How about funding into more well-being initiatives? Is there any plan on doing any more with that? Since mental health needs have escalated, is there any plan in doing anything?
A lot of our prevention work is
Yeah.
focused in this area. We also received dollars last year to do a public awareness campaign around wellness, mental health. So that will be implemented as well.
All right, and thank you for that and for being here. And if you could send us that information also, so we can put it out, so that people can know that, that's going on.
Thank you for the question.
Appreciate it.
Thank
Thank you,
you.
Madam Chair.
Representative Nuccio, followed by that Representative Datham, and after Representative Datham, Representative McCarty.
Thank you very much, Madam Chair. Hi, how are you?
Good, thank
Somehow my chair got put down again. I can't see over the top. Short girl problems. I have a couple of questions. I'm hoping you can answer for me. The first one is regarding the transfer of the funding from DSS to support contract services at 60 West. In DSS, those were in the Medicaid line, and now they're in the nursing home contract line. Were we getting any kind of match while they were in Medicaid?
No, because those are for uninsured.
Therefore, okay, so we're not losing out on any match by changing this from
Correct.
Medicaid to here.
Yep.
Okay, that was my first question. The second question I have is regarding the reallocate funding for behavioral health ASO. There's also a secondary line, provide funding for behavioral health partnership ASO contract. I'm trying to understand what these are doing and what these fees are, and what the total is, because it looks like they're general assistance managed care. I'm not quite sure what that is.
So we are part of a partnership with DSS and DCF, the Behavioral Health Partnership. And we share ASOs, Beacon Health Options, and now we're working with ABH, Advanced Behavioral Health, to do some of the work around the SUD waiver. Previously, there were separate contracts for the waiver and for a program that's known as CHESS with DOH and DSS and DEMIS. Both of those projects are now incorporated into the base contract that we have with Beacon. And this is our percentage of that.
So I guess that's, so what is the contract for? Because what do we provide?
They're
'Cause
in
an
a-
ASO contract means we're self-funded I'm assuming that's what this is.
It's an administrative service
Right.
organization.
Yep, that's the
Right, so
self-funded.
they do authorization for us. They do a lot of data analysis for us, quality measures for us, monitoring.
So it's the administrative, it's the administrative portion
Correct.
of the insurance contract. Now, what is the insurance contract base then? If this is the administrative portion of it, who are we insuring? What is the behavioral health?
This is all the Medicaid folks,
So it's the behavioral health portion of the Medicaid
correct?
contract.
So it's on the behavioral health side, it's Beacon Health Options. The other side, the primary care side, it would be CHN. You may be familiar with CHN.
Okay. That makes sense. Thank you very much.
You're welcome.
Representative Dathan.
Thank you very much, Madam Chair, and thank you very much, Commissioner, for being here today. It's good to see your team. Just wanted to understand with the decreases over what the agencies asked, requested for in the home and community-based services and the discharge and diversion services over what was provided in the final budget. And I know that there's some differences, and I'm wondering, are we going to be able to satisfy our needs with a lower budget? And maybe if we can have some sort of breakout within the working group of how those funds have been spent historically and how you envision those funds to be spent in the future.
Sure, be happy to do that. And just briefly, in the home and community-based waiver, we have had lapses. And so that was if you're referring to the $2 million, that is what we have historically been lapsing. So that works. That is what we propose. So that is fine.
Just to follow up on the lapses, is this a result of timing from when the fulfilling nonprofit or whoever's getting the money gets the money, and then they can't either hire in time or use the money in time because of disbursement policies?
No, it's actually the flow, the cadence of money follows the person. So we're like the next step to money follows the person. And so if the referrals are slow coming through that way, we may not be spending the money as quickly.
Can you provide, just as a follow-up, a number of the people that are in process of getting referred, and maybe, I don't know if you want to call that a wait list or whatever. If you could provide those numbers and maybe a trend where we have been historically and where we are today, because I'm really curious how that kind of flows within the lapses that we see. My second question is around the cannabis prevention. I understood that the total fund was going to be about 15% of the revenues, and it looks like it's a bit less. And I was also a bit surprised to see the comment in one of the sheets that it is also for it is for, there's a number of things that you're doing. Oh yeah, here it is. Media campaigns, secret shopper campaigns, and grants to local prevention. Why is the secret shopper program within your agency and not DCP?
Historically, it has been. We've successfully received federal and state dollars to do that for the tobacco products as well. So vaping, cigarettes, any tobacco products, we do that. And the FDA dollars as well as the state dollars go through DEMIS.
Okay, maybe if you can bring to the working group a breakout of how you envision those, the budget here of state dollars as well as the federal dollars for each of those programs, and would like to get an understanding about how the grants to local prevention entities will be, how that will be split out, utilized within our communities. Is it a function of education, or is it a function of other sort of community nonprofits that are working for prevention services?
So these are the proposed dollars. So I'm not sure
Right.
all of that has been figured out. But
we have
certainly-
spent some in 23, I understand. So we have some historical.
Yes, we did
okay.
media campaign.
Okay, so that was solely for media.
Yes.
Okay.
Yes.
That'll be kind of good to understand. I know I have a lot of nonprofits that are working towards trying to prevent youth and other people from utilizing cannabis. And I'm really curious how this is going to be spent. I know we're seeing a lot with the sort of Delta 8 and Delta 9, and then there's a lot of worry about that. I know the Attorney General's looking at that. General Law has a bill in that's dealing with that. My last question is regarding the private providers, the 50 million in ARPA funding. You had said that the fiscal year 22 went out as directed and fiscal 23 is in process. Could you just elaborate what the timeline is for that, and so that, you know, if when our nonprofits are expected to get that money?
I believe it all went out. All of that money has gone out.
The fiscal 23 money?
Yes.
All of it. Okay, because it said on the sheet it was in process.
Oh, minus the last quarter. I'm sorry.
Okay, great. And about how much is the last quarter?
We can get back to you.
Okay, yeah. And if you can just provide an allocation, how those funds were dispersed. Sure, that would be great. Thank you so much. Thank you, Madam Chair.
Thank you. Representative McCarty.
Thank you very much, Madam Chair. Welcome, Commissioner, and to
you.
your staff. Good to see you. Thank you for your testimony. I'm sorry I missed some of it in the beginning, but if I may just go back for a moment to the opioid epidemic. I know that looking at the numbers that we still need to do a lot of work in that area. Could you just speak briefly what your department, do you have any new programs that you might be interested in, how we could help with curtailing the numbers that continue to increase? Any idea for new services that may be eligible? And then if you wouldn't mind, to the working group, you do talk about the residential detoxification programs. If you could just bring us some more information in that regard, I would
Sure.
appreciate it. And then finally, I finished just one little bit more. I'm looking at the budget book actually, and a lot of the funding that we've received from the federal side for some of these programs. Can your agency bring to us how you will, going forward, how we are going to fill that gap for those new services that are provided with the federal dollars? I would appreciate that.
Sure. Most of them are being continued, I'm happy to say.
Well, I see there's an extension out till 2025, but after that, will they continue beyond that?
Oh, I see what you're saying. It's hard
Yeah,
to say.
because
in
the ARPA
next
funds go
biennium.
out and you use them the following year, but I'm concerned because, you know, the opiate epidemic is something that we really have to focus on.
Mhm.
And I'm particularly concerned on the recovery centers and tracking and following the individuals to watch that they don't come back into the system or that they overdose because they're not getting that appropriate aftercare. I think there's more that we can do in that region. Just wondered if you thought about that and if it's anywhere in your budget proposal.
I think about it every day. It's something that weighs heavy on all of our minds, that these deaths are happening. Connecticut has had a very aggressive and progressive plan to address the opioid crisis. We're meeting our goals in terms of Narcan saturation. For example, we work with our sister state partners around Narcan distribution, working with syringe exchange programs through DPH, harm reduction, and our regional behavioral health action organizations, getting prevention messages out. Actually, a lot of the funding for recovery centers, for example, and some of the other core services that comprise the infrastructure for opioid treatment and other substance use treatment is through our block grant and through our core state budget, that you're not seeing the additions here, but it's enmeshed in our core budget regarding our continuum of care. So those will stay in place.
Right. And you touched on the point that I was trying to get, because I know a lot of this funding comes from the block grant, but what I'm suggesting is that we really look on the state side, what more we can do, because I think there's that, and you've said that very well, that there's still the need there and we have to continue doing that work. And if I may, just a personal shout out to Jenny Milstein, because she came forward with the language for the Navigator program, and I think that will do some good. We've got to continue in that direction as well. And then if I may, this is all it's kind of a little comment on the brain injury piece. I think that comes out of a federal block grant as well, right? The waiver, the brain trauma.
We don't do the waiver, we do some other services.
Okay, because I've heard maybe just, how is that, is there oversight in that program? How does that work?
Sure, we can get some more narrative to you in
Yeah.
the work group, but yes, that's a well-functioning unit. It operates out of the CVH campus. We have inpatient, outpatient, wraparound services for people.
Right, you have a large department. We're all still trying to get all the
Yes,
pieces
yes.
put together, but I appreciate all of your work. Thank you very much.
Thank you for the questions.
Are there any other questions? I have one question, broad question. At Whiting and at CVH, are the people that are at Whiting and CVH court ordered in all cases?
No, they are not.
Are they court ordered for just Whiting in all cases?
So Whiting, we get referrals from DOC. We have civil, voluntary and involuntary clients, and we have PSRB clients. So we could have, we can also have people end of sentence from DOC. So it's a restoration to competency is another group of folks. So different reasons why they're may be referred to Whiting.
So Whiting may not be court ordered, but their agency requested? Because DOC can't order somebody to go anyplace, right? So
Oh.
if you have, the Department of Corrections says to you, we have somebody that is at their end of sentence and they are not quite ready for being out in the general population. So is there a conversation that happens with that person?
Yes, it's all done very clinically, and there would be team meetings and assessment of folks. Absolutely,
And they would go to Whiting, not to CVH.
correct.
Is CVH like an old psychiatric hospital?
I'm not sure what you mean by
I
that.
mean, that they're not necessarily court ordered, but they're people that need additional,
There are people that are there voluntarily. Yes,
and the old state psychiatric hospitals had people that were there voluntarily.
I would think so, yes.
Okay. Thank you very much. Representative Exum.
I'm just curious, as a follow-up on that question, are there other locations where individuals may, who are kind of court ordered, is there other places that they would go who have some oversight or may have a conservator or something like that, other than the two facilities that we just mentioned?
There are many people that or providers that offer hospital level of care across the state. There's only one forensic psychiatric hospital, which is Whiting Forensic Hospital, which is comprised of Whiting Max, which is maximum security, and then the step down part of Whiting Hospital, which is Dutcher.
Okay.
But, folks may have conservators and just be living their lives among us or in the community and maybe going to outpatient therapy.
Outpatient, and is there sometime though mandated, like places that they stay, but it's again, not Whiting or the other facility? I'm just trying to understand. Maybe this is something I should ask you later. I'm just trying to understand.
Okay, yeah,
Miss, I'll talk to you offline.
Sure.
Thank you. Thank you, Madam Chair.
They could be in the Department of Correction. There are a number of people in the Department of Corrections with mental health issues.
There are beds in the community that are run by our forensic department as well. So we fund providers to provide services for individuals in communities, again, various levels of care and degree of oversight.
Anybody else? Any other questions? Commissioner, I don't see anybody online either. I think you're all
Okay.
set.
Thank you so much. Have a
Thank
great
you.
weekend.
We'll see you at the working group.